in 2 minutes, Dr. Sharma.
Yes.
So good morning, everybody. Thank you for the attendance. So these are one of the sessions of neonatal reviews for neonatal fellows. And today it's my pleasure and my honor to welcome my friends and my colleagues, Dr. Sharma, very well known, one of the giants of neonatology, working in UK and main interest in neonatal resuscitations and procedures. Many activities in addition to the neonatal care, including conferences and very active neonatologists on social media, lots of experience. I'm sure today me and you will be enjoy the time, having knowledge and get more experience in neonatology. Dr. Sharma, you can start.
I'd like to thank Dr. Ethwi for giving me this opportunity to speak to you today. First of all, thank you for the introduction. What I'd like to say is that today I aim to learn from you, and the intention of my talks is to give you a little bit of an overview. To start off with preterm resuscitation, a few of the physiological pointers, followed by actually what we'll probably say will be a talk on the recent updates in preterm resuscitation. I would like to then finish off by actually giving you a little bit of an overview of how human factors actually impact neonatal resuscitation, in particular with COVID. That's been quite an important aspect of how we manage care. In terms of resuscitation, and starting with my talk on preterm resuscitation, what I would like to say is that preterm resuscitation is about smaller, less gentler, and in some cases more. What we'll aim to do is take you through how the physiology of preterm babies, especially under 30 weeks, differs from near-term and term babies. And this module in particular emphasizes the physiological differences that we find between extremely low birth weight and very low birth weight preterm babies, with a view to taking you through resuscitation and looking at how the steps of resuscitation, when practiced appropriately, allow us to produce good neonatal outcomes in the delivery suite. Now, we all have different guidelines. The NRP is practiced in the UAE, in the United States, in Canada. And if you come to the UK, what you'll find is that actually we practice the neonatal life support, and there are minor differences, but the overarching principles remain exactly the same. There is what we would call a DT-ABC approach, which looks at delayed cord clamping, looks at the thermal care, management of airway breathing, and circulation, in that order. And the general principles around resuscitation remain the same. I think the challenge for us is how babies manage, despite minor intricate differences between practice across the world. I think from my perspective, what I am going to do is take you through the learning around the processes and the principles involved in preterm resuscitation. And I think the key thing to emphasize is we have a structured approach to all neonatal resuscitation practice, which usually starts in delivery suite when the baby is born with delayed cord clamping. Thermal care is a very important and I would say a relatively neglected part of preterm resuscitation, but one that's highly critical, as I will discuss later on. That then involves simultaneous management of airway breathing, and circulation follows. I think the most important thing from our perspective is, what do we define as a preterm baby? And clearly, when you talk about physiology for preterm babies, one of the important aspects of management of preterm babies is differentiating near preterm babies from those babies that are actually extremely preterm. And I think we'd all agree that babies born between 34 to 36 weeks plausibly will behave clinically like babies born between 37 to 42 weeks, in that they usually come out and the majority of them will stabilize without the need for any significant resuscitation. For babies between 31 to 33 weeks, they are more immature. And I think the key aspect of managing their care is the fact that some of these babies will need breathing support, but a proportion of these babies will also be surfactant deficient. And in those situations, they will need help and aid in transitioning to breathing, as well as to need for surfactant in order to stabilize them. Babies 30 weeks and below are a completely different population. And while the resuscitation principles around resuscitating these babies remain generically the same, we have to adopt a strategy that actually looks at them in terms of not just their size and immaturity, but also their physiology, which is different because of a variety of reasons that we're going to talk about. I'm going to start a little bit by talking about the physiological principles of delayed cord clamping and the advantages. And what I'd like to do from my perspective is see if any of you are using and practicing delayed cord clamping. So can you all hear me?
Yeah, we do.
Yes.
Okay.
Yes.
So just wanted to get a little bit of an idea. How do you practice delayed cord clamping in your setup?
Asking me or asking the audience?
I was asking the audience, Dr. Ethwi.
Okay.
In Cornish Hospital, we delay for term babies. For preterm, we take sometime 30 seconds to 60 seconds if they are stable, or sometime they milk the blood. I mean, they just push some blood to the baby. For term babies is definitely 1 minute complete.
Can I ask, do you do delayed cord clamping, then start resuscitation, or do you resuscitate your preterm babies simultaneously?
No, actually they do the first, they don't, because the obstetrician who is the one doing that. So just they delay if the baby looks stable breathing, they delay the cord clamping. If the baby flat and looks unwell, just they milk some blood and give us the baby quickly. We are speaking about ex-preterm. For term babies, almost unless asphyxiated, everyone will fall for delayed cord clamping.
Okay, that's absolutely fantastic. And how do you keep your babies warm? Do they go into a plastic bag immediately?
Yeah, 32 and below for plastic bag on, just the baby out. The midwife will put in plastic bag and hand over to us, the neonatologist.
Okay, so just to give you a little bit of background, I mean, I'm going to feed you eggs now by saying that actually delayed cord clamping has numerous advantages, both in the term and in preterm babies. And I mean, I think the evidence would unequivocally state that some form of delayed cord clamping is now recommended as part of resuscitation algorithms worldwide. I think the benefits in preterm babies, as per a large number of studies, in particular done by Heike Rabe, one of my colleagues in Brighton, reports benefits which include a reduced incidence of IVH, decreased inotrope support, and importantly, we've also seen improvements and reduction in the incidence of necrotizing enterocolitis and late onset sepsis. I think the challenge for us when we're implementing delayed cord clamping as part of a resuscitation guideline is the judgment about whether that baby needs help or resuscitation, and the balance between choosing babies who we think are stable enough to be able to have it, keeping them warm, implementing delayed cord clamping, and from our perspective, what I'd like to do is take you through a little bit of the physiology behind delayed cord clamping, because from a preterm perspective, it is absolutely crucial that we understand this. So if you look at the slide on the left-hand side, which talks about early cord clamping and impaired ventilation, we're kind of in a situation where when the baby is born, we have fetal circulation, and all the blood is predominantly coming to the right side of the heart from the placenta. It goes from the right side of the heart into the pulmonary tree, which is full of fluid and has a very high pulmonary vascular resistance. That obviously means that the lungs aren't the oxygenating organ, it's the placenta that's the oxygenating organ. And a proportion of this blood will actually, significant proportion of this blood will short circuit to the left side of the heart and get supplied to the systemic circulation. Now, when the baby is born, traditional practice before the implementation of delayed cord clamping would technically involve clamping of the cord, which would then mean reduced preload to the right side of the heart, but more importantly, an increased afterload from the left side of the heart. And in a baby, say, for example, who's not breathing, because the pulmonary vascular resistance would be high and the pulmonary venous circulature would be vasoconstricted, there would be a situation where transition from our perspective, while it takes place, does not take place with additional blood volume that can result in stabilization of extremely preterm babies. Now, when we look at the extremely preterm baby, what is absolutely crucial from our perspective is that we enable transition. And because a significant proportion of these babies often, especially under, I would say, 26 weeks, breathe, I would say, ineffectively or need help with breathing, there is evidence to show that if you delay clamping of the cord, you enable a placental transfusion, which, depending on time, can vary from 10 to 20 mils per kilo, which supplies excess blood, which eventually reaches the right side of the heart. Now, if I look at the right side of the heart, blood acting as preload reaching the right side of the heart eventually ends up in the pulmonary tree, back to the left side of the heart, improves cardiac output. And this results in what we would call significant cardiovascular stability. Has numerous advantages because the increased circulating blood volume allows a more stable transition of the baby, effective cerebral perfusion. And what you can see from our perspective in this diagram that I have over here is the relationship between blood volume when you delay cord clamping. And what you can see is that as the infant cord clamping is delayed in time and birth after minutes, the infant blood volume actually increases. Now, this physiological transfusion that takes place is time dependent with a volume that increases with time. But what is increasingly being recognized is that actually if you are enabled or in a position to be able to enable breathing support of this baby, then you reduce pulmonary vascular resistance and improve blood flow to the pulmonary tree, which enables a redistribution of blood flow, improves cerebral blood flow, and actually improves the amount of volume of blood that the baby actually receives. And this has been demonstrated by Stuart Hooper and his group in the Ritchie Center in Australia. Now, one of the crucial things for us when we talk about delayed cord clamping and physiology in terms of extremely preterm babies is, how do you do that? B, what's the evidence that that actually benefits in real life, in particular when we're resuscitating extremely small babies? And the majority of protocols, especially for babies under 30 weeks, still focus on more a time-based protocol, which means that you delayed cord clamp and then initiate resuscitation. We'll talk a little bit about this when I talk about resuscitation practice. The differences in preterm babies as compared to term babies also means that they are increasingly prone to having problems with hypothermia. And actually, when we try to keep and warm them, what we often create is hypothermia. And I would argue to you that actually, at the moment, focus has moved away from just preventing hypothermia in delivery suite, but very scientifically to trying to promote normothermia, because we don't want babies getting too hot if we're trying to prevent them from getting cold. And why are these differences quite paramount? So again, I'm sure you're all aware, preterm babies have very immature skin, reduced subcutaneous fat. They have poor vasomotor tone. Their ability to vasoconstrict in the skin and actually keep that heat within them is actually significantly impaired. In particular, they have a high body surface area to mass ratio, which kind of means they are prone to loss of heat, both through evaporation, through conduction to the surroundings, and in particular, when we're in a situation where the baby comes out wet and moist and is taken from an environment in the mother's womb where the temperature is about 37.5 to a temperature which, you know, theoretically in theaters, if we can get them up to 26, they suffer quite significant drop in temperature, which from our perspective, we need to be careful about, because hypothermia causes surfactant inactivation. Pain from hypothermia causes apnea. And what we know is that there are significant morbidities for babies who come to the neonatal unit hypothermic. So work from the Epicure 2 study, which was conducted by Kate Costello and her group, showed that for extremely preterm babies under 26 weeks, for every degree under 36 degrees, 36.5 degrees, that the baby reaches the neonatal unit, the mortality increases by 28%. And one of the crucial things that we really worry about for babies who are extremely hypothermic, say temperatures under 32.9, is the risk of having intraventricular hemorrhage, besides problems of metabolic acidosis, lactic acidosis. What we've noticed is in studies, observational studies, that mortality for these babies can actually be as high as 80%. Our aim is obviously to keep them warm, and we'll talk about this more when I talk about resuscitation of the preterm babies. But what I'd like to really come on to is how we manage babies in terms of establishing ventilation. And I think probably keeping in mind all the steps, all the TABC steps, this is the most crucial aspect of trying to resuscitate preterm babies, and that what we want to do is inflate their lungs, which are fluid filled, cause redistribution of that fluid, enable gas exchange, but then from our perspective, establish an FRC. I think alongside that, what is very important is that we want to practice lung protective ventilation strategies during preterm resuscitation that don't damage the lungs, and also want to enable babies to breathe. And I'm going to talk a lot about the physiology behind how a preterm baby initiates breathing. To start off with, what I would like to do is give you a little bit about the differences and the physiology between term, near-term babies, preterm babies, and extremely preterm babies. And what you can see on the left-hand side over here is a term baby being intubated by a video laryngoscope. And clearly, when you look at that airway, this is a baby that's just been born, and you can see fluid being extruded. So when we resuscitate term babies, their lungs are fluid filled, and when they take their first breaths, these babies will often extrude as much as 30 mils per kilo of fluid during that first try. What you can see, and when you extrapolate that to preterm babies, is can you see how this baby is breathing and how the pharynx is moving while it breathes? Now, this is an extremely preterm baby. This is a 25-weeker who we're intubating. And what you can clearly see is, I mean, this is a delivery room intubation where we're giving this baby surfactant, but this baby actually is not breathing. Can you see how the pharynx does not move? Now, this is absolutely crucial in that because these babies are extremely small, have quite immature breathing apparatus, they often do not breathe unless we stimulate them and unless we're able to get them well recruited from a lung perspective, inflate the lungs using what we call is the herring-brewer reflex. Now, as you can see, the airway of a preterm baby, a 25-weeker, compared to that of a term baby that you'll see over here, you can see the difference in dimensions, size. You can see how, from our perspective, I will demonstrate, the cords, if you look at them, are moving. This is a breathing baby. So actually, from our perspective, this baby, while I'm intubating it, is able to abduct the cords, allow fluid to come out. Whereas in this preterm baby, the cords are predominantly in the adducted position, and a lot of the fluid gets retained. If you also look at the fact that preterm babies are going to have surfactant immaturity, there's a lot of help that preterm babies will often need in enabling a transition to breathing, for them to be able to transition, get those fluid-filled lungs, extruding that fluid out, and then having to cope with surfactant immaturity. Now, this is a baby who, obviously from our perspective, again, you can see who's been stimulated. Can you see how the baby's breathing? So abducting and adducting, but I'm still having difficulty putting the tube in. And one of the things that I'm going to talk about in subsequent slides that is new and upcoming in preterm resuscitation physiology is the fact that preterm babies, often when they breathe, will still keep their vocal cords adducted. And that, from our perspective, creates significant issues with preterm resuscitation. In that often we try to resuscitate these babies. We will start mask-based PEEP if they are breathing. If they are not breathing, we will often start what we call IPPV with a mask. But actually, when you apply the mask to the face, that stimulates the trigeminal reflex. But more importantly, preterm babies are behaving fetally, and they tend to have glottic adduction. And actually, if you apply too much pressure with the mask, or there are too many painful stimuli, those cords remain adducted, and your ability to be able to initiate mask-based PEEP or inflation of the lungs is significantly impaired. If you look at the size of the airways, the problems with their breathing, their central breathing, the fact that they have surfactant deficient lungs, and you combine that with the fact that they have fewer respiratory muscle fibers that are rich in mitochondria, the preterm baby is in a physiological milieu that actually makes it very difficult to self-initiate resuscitation, stabilization through its own breathing. Now, what I'm going to do is I'm going to talk about that physiology one by one, and I'm going to take a head to lung approach. And what I'm going to emphasize is that when the baby is in the mother's womb, often what you'll find is the lungs are fluid filled, and the fluid in the lungs acts as a splint which keeps those lungs open. Albeit those alveoli have significant amounts of fluid, which kind of means that actually they're not aerating the baby, but the baby or the fetus, while it's in the mother's womb, is being supplied oxygenated blood from the mother's placenta. When it's being born, it takes and starts breathing in certain cases. And when it breathes, it generates negative intrapleural pressure, which actually helps to draw the lungs open and helps the alveoli open. In a way, it's the chest wall that is then encouraging the lungs to stay open when the baby inspires. And what is quite crucial, as you will see, is the fact that central stimulation of the baby's breathing causing the chest wall to expand during inspiration, producing that negative intrapleural pressure, is one of the key steps in allowing the lungs to expand, aerate. But the baby has to do this if it's born preterm in a setting where it has to breathe against a adducted or closed larynx. And that is the fetal nature of breathing that persists when babies are born extremely preterm. Now, crucially from our perspective, resuscitation strategies or stabilization strategies as espoused and as practiced by the NRP and the NLS not only need to think about the fact that we need to inflate the lungs by providing volume, what we also need to do is be able to enable a physiological transition of central breathing in order to allow glottic abduction so that the baby can transition effectively. And this is a very key aspect of physiological application that we have to apply, especially if we're using CPAP or PEEP during the breathing process. So if I just elaborate on that, most preterm fetuses show weak and ineffective breathing alongside the management of babies, where what we want to do is make sure that we're in a situation where babies are able to let fluid out of their lungs. Now, for preterm babies who establish spontaneous breathing and cry, this process is initiated by the baby, and we help the baby either through PEEP or positive pressure if it's breathing ineffectively. However, for babies who are apneic, this fluid does not egress, and if you take surfactant deficiency, that is a double whammy. What we also need to enable, as I've spoken about, is that we're enabling the baby to breathe in a way that its larynx actually is able to open in order for us to deliver positive pressure ventilation or PEEP in order to enable this baby to breathe. Now, there are a variety of reflexes that come into play when we apply PEEP to babies, and some of those reflexes themselves help in stimulation. So when you apply a mask to a baby and you keep it in neutral position, you have good seal and you're applying the appropriate size mask with the appropriate pressure. You are splinting the upper airways of a preterm baby open. More importantly, you are also stimulating inflation of the lungs and the Herring-Brewer reflex, which enables the baby to breathe, enables the lungs to get inflated. But if you apply an extremely high pressure while applying the mask to the face, what you actually do is you stimulate the trigeminal reflex, increasing glottic adduction, impairing ventilation, increasing apnea, and actually paradoxically make things worse for yourself. So I'm going to show you a few slides courtesy of Dr. Hooper. And if you look at the slide on the left-hand side and look at the implications of breathing in lung inflation. So this is the baby that's breathing, and you can see how well the airways are splinted open. So this is a plethysmograph, which is monitoring breathing. You can see the spike of breathing over here. And when the baby breathes, which is now, you can see how the alveoli open up. So you can see a very grainy appearance, which is the alveoli, but you can see how the airways are splinted open. If I elaborate on that in more detail, this is a slide of the baby as it's breathing. And what you can see where I'm putting the pointer is the glottis. So as the baby takes a breath, and if it's spontaneously breathing, as you can see here, the glottis abducts and adducts, and this allows good lung aeration, which is what you can see over here. So this is a very well expanded chest, which expanded up to 9 posterior spaces. What is crucial in these babies is that we are helping them breathe. So these are preterm rat pups. But most importantly, from our perspective, there is a crucial role that the chest wall, the negative intrapleural pressure, which the baby is able to generate, which helps to keep these alveoli and lungs open. And the more you're able to initiate this process, the more help you will have when initiating non-invasive ventilatory support in the delivery suite. Now, to make that more obvious to you, what I'd like to show you here is a baby that's not breathing. And if you look at this baby, his lungs are completely white, they're collapsed. But more importantly, if you look at my cursor, this is the glottis. And can you see how when the baby is not breathing, this glottis is completely in adducted position. So what is really important is that if we're in a situation where we apply mask-based PEEP for delivery and inflation of these lungs, what will happen is this pressure will distend the upper airways. It will also, the pressure on the face, encourage the baby to breathe. And this breathing will help open the glottis, which then helps this air get delivered to these lungs, which will then allow aeration of these lungs, which I will show you in this slide. So if I show you this slide, your focus would be the glottis over here. And what we're going to show you is a baby where we're initiating mask-based PEEP. And what happens? So you can see the baby started breathing. And you can see how the glottis, can you see how to start off with when we start, and if you apply very high pressure, this glottis actually remains adducted. But now as the baby starts breathing, can you see how the glottis starts opening up? And what you can see is there is gradual aeration of the lungs becoming much whiter. Now, this is very, very crucial because when the baby breathes, the more immature the baby, the more the central drive would promote reflexes that actually cause the vocal cords to remain in adducted position. And what is really important is that when we initiate the delivery of pressure and PEEP in delivery suite, that we are enabling this transition with a gentle approach, focusing on a clear application of the mask of appropriate size so that we are maintaining effective seal and not having any loss of pressure. What is very important and the natural tendency of a lot of trainees while they're learning how to deliver mask-based PEEP or IPPV is they apply a huge amount of pressure on the baby's face. What I'd also say is that at 23 and 24 weeks of gestation, often babies' faces are increasingly pliable. They are very, very fragile. And the more you apply pressure to that mask when you're initiating ventilation to trying to inflate those lungs, the more the baby's face will mold. And actually, paradoxically, what has been seen is that when we train trainees using a specialized device to look at the mask leak, if they apply too much pressure, the mask leak goes up because you tend to deform the face. What is important and what this video clearly demonstrates is as the baby starts breathing, and again, if you keep your eye here on the glottis, can you see how the baby's starting to breathe because the glottis is adducted? And actually, we'll now apply PEEP to this baby. And what you'll see is the PEEP application causes this baby's lungs to inflate, start breathing. Can you see how the glottic movement actually becomes more physiological? This is because the upper airway here, and you can see the difference, the distension in the upper airway as pressure is applied, but you can also see aeration of the lungs. Now, aeration of the lungs is an absolutely crucial step in allowing transition of a baby, both from a respiratory, but also from a circulatory perspective. So if you do not aerate the lungs, the alveoli do not actually expand, they do not aerate. But more importantly, what happens is the interstitial spaces where you have blood vessels remains completely full of fluid because alveoli are completely collapsed. And actually the breathing, which encourages blood flow to the pulmonary circulation, a drop in PVR does not actually take place. So this is a video courtesy of Dr. Stuart Hooper, which actually shows a non-breathing baby. And what you'll be able to see is what happens to the pulmonary circulation. So these lungs are white with RDS. And what you can see is there is perfusion, but the perfusion is only in the main pulmonary arteries. There's absolutely no perfusion in the distal parts of the lung. And this is because the alveoli completely collapsed. There is intense pulmonary vasoconstriction still persisting. What you've got here is a fetal circulation. So this is a baby who's not breathing, who has quite significant surfactant immaturity, completely white lungs, alveolar atelectasis at this particular point, with intense pulmonary vasoconstriction with the fetal circulation. And the perfusion in these lungs is predominantly in the pulmonary arteries, but absolutely no distal perfusion. Obviously, we haven't applied any PEEP, we're not supporting this baby. But what happens when you apply PEEP and support these babies? Well, this is one where we're not applying PEEP, but the baby's breathing spontaneously. And again, what you can see is that we're aerating the lungs, but we're not really aerating the lungs sufficiently. So while the main airways are recruited over here, what you're not able to see is the distal airways being recruited. So these alveoli, these small, you can see the bronchioles, you can see a little bit of recruitment, but the alveoli that, say, for example, the baby is breathing with are surfactant deficient. They have a tendency to collapse. They're not being recruited. So while this is a baby breathing without support, we're kind of in a situation where we still have not transitioned either from a respiratory perspective, nor are we in a situation where you'll have good pulmonary blood flow. So the ability for this baby to transition both from a respiratory and a cardiovascular perspective has not happened yet. On the other hand, you can see clearly this is a baby where we're using PEEP. And what you can see is not only are we recruiting lung to the distal parts of the lung fields, the alveoli are being recruited really nicely. The baby's breathing spontaneously, and we're just applying PEEP. And this is a PEEP of 5 at this particular point. What you can see at the alveolar level is that these alveoli are well recruited and in a situation where they show much more stability with less collapse. Now, if we're able to aerate lungs effectively, the alveoli expand, fluid gets pushed into the interstitial space, gets reabsorbed, and we also see a transition where the pulmonary vascular resistance drops, which means pulmonary pressure in the pulmonary tree drops, allowing blood flow from the right side of the heart into the pulmonary vascular tree, which then allows better oxygenation of this baby. Now, the fetus, obviously from our perspective, is relatively hypoxic. But as you transition in preterm babies, what is absolutely crucial is that we're enabling a transition which is needed by this baby, but is not damaging. And what we have to be sure is that we are protecting the lungs. So if you apply too much PEEP and overinflate these lungs, or if you're in a situation where you apply positive pressure ventilation at very high pressures, what results is damage to the alveoli, and this damage eventually sows the seeds for chronic lung disease later on. And a variety of strategies for lung recruitment in delivery suite are currently being practiced in different ways, some of which obviously from our perspective are better than others, and we'll talk about them in the next presentation. But this is just another slide which emphasizes the importance of PEEP. And what you will see is this is the distal alveolar recruitment that we see in the previous baby. And can you see how with PEEP in a spontaneously breathing baby, you can see how recruitment takes place right up to the distal alveoli. So the use of PEEP in preterm resuscitation is critical. And what I would say is that T pieces, which are widely used now, I would say everywhere, consist of and allow a mechanism for delivery of PEEP along with positive pressure ventilation for the baby that's not breathing. But more importantly, for babies who, say, for example, are breathing, you can deliver sustained PEEP, something that is very, very difficult to deliver, even with, I would say, flow or self-inflating bags, which have PEEP valves. They're not as effective as T pieces in being able to deliver sustained PEEP. And what you can clearly see here with time is the ability of alveoli to be recruited if PEEP is delivered in a sustained way using a T piece. A key and crucial aspect after you've aerated the lung is circulatory transition. And what is very important is, from our perspective, is once a preterm baby starts breathing, or if we're in a situation where this baby is not breathing and we're applying or giving this baby intermittent positive pressure ventilation, that at the circulatory level, there are significant changes taking place. As we discussed, when you aerate the lungs, you have a rise in partial pressure of oxygen. And this partial pressure of oxygen rises in the pulmonary capillaries after being transferred across the alveolar epithelium. That drops the pulmonary vascular resistance. And what you eventually have is increased blood flow to the right side of the heart. Now, if I contextualize delayed cord clamping, the increased blood volume that's delivered by placental transfusion improves the preload of the right side of the heart. And if you remember Starling's law, that preload contributes to improved pulmonary blood flow because your pulmonary pressure has now dropped. So actually blood flows to the lungs, gets oxygenated in the lungs, comes to the left side of the heart, and eventually the left atrial pressure rises, and a rise in left atrial pressure closure of the patent foramen veil. That prevents right to left shunting or intracardiac shunting from the right side of the heart to the left side of the heart, which used to take place in fetal life. Now, this then makes this circulatory apparatus in the heart work in
Dr. Sharma, you have 10 minutes.
Yeah. And what eventually happens is we're kind of in a situation where we are able to transition to supplying the systemic circulation. If I look at the transition of circulation, these are 3 amazing slides. And what you can see here is that this is a baby who obviously is breathing well. And you're kind of in a situation where we're ventilating it well. Now, as discussed previously, what you could see is in a baby who's not breathing, who has significantly wet lungs, which are full of fluid, you can hardly see any peripheral circulation. On the other hand, this is a baby who has transitioned and is breathing effectively. And what you can see is that the pulmonary vasculature and circulation reaches the peripheral parts of the lungs. So you can see how transition and inflation of the lungs actually allows for much better circulatory transition. I'm going to skip the slide for the interest of time, but this is just to show you the ductal shunt. And this is a baby who I've echoed at 2, 4, 6 hours. And what you can see from our perspective is the shunting. And here you can see complete right to left shunting across the duct. But with time, what is happening is you can see some flow backwards as well. And this is bidirectional shunting, predominantly still right to left. But at 12 hours of age, this baby has started shunting across the duct from left to right. And actually, this will allow this baby to get pulmonary blood flow, but gradually with improved oxygenation across that duct, the duct will close. And what you will eventually get is a mature circulation. So if I summarize, what is really important from a physiological perspective is that you have quite significant differences between preterm babies in that enabling them to have placental transfusion helps enable circulatory stability and transition after birth. Preventing hypothermia and hypothermia has significant physiological advantages. But more importantly, from a breathing perspective, most babies have an immature central breathing apparatus. The glottis behaves fetally with adduction. And these babies have a higher propensity to fatigue in addition to being surfactant deficient. So what I would like to do is say that actually most very preterm babies will need some form of help, especially if they're under 30 weeks, in order to transition to air breathing. I'd like to stop there before I go on to my next presentation, which would be preterm resuscitation. But what I would like to ask is, does the audience have any questions at this stage?
I do have some questions, if you don't mind.
Please.
So for the resuscitation transfusions, whether it's a delay cord clamping or milking, like in your practice or in your experience, is it better to continue until the baby start breathing? And from that point, do you prefer the resuscitation to start while we are in on transfusion? And I don't know, I see the reason why we do delay cord clamping or milking for stable baby and not to do it for unstable. And I think these are the babies who will have problem and they are risk of abnormal transition.
I'll be really honest, Dr. Ethvi, I would agree with your premise that actually it's the babies who are not breathing, or say, for example, who are transitioning, who would benefit quite significantly from this transition, alongside babies, say, for example, who are breathing. And the question from our perspective is how we can enable this. So if you could resuscitate in parallel, enable that transition by actually resuscitating the baby bedside with the cord intact. That, in my mind, would be much better. And that is practice that we would aspire to. The problem that we face with extremely preterm babies is the ability for the team to assess which of those babies needs resuscitation and transition versus which of those babies don't. And the risk in the situation where, say, for example, you're practicing that in an environment where you can't keep the baby warm, or you can't resuscitate the baby effectively. And a good example is, we practice resuscitation on resuscitors, but what if the baby's cord is so small that you can't get that baby to the resuscitor? The challenge then from our perspective is, if you're not doing that in a controlled manner with good communication, or where the mother is at risk of complications, where she bleeds excessively, then there is a risk that there may be harm to both baby and the mother. If you look at studies done by Stuart Hooper, what they've clearly been able to demonstrate in animal studies on lambs is that actually if you initiate resuscitation, you drop the PVR by lung inflation. The negative pressure that's generated in the intrathoracic cavity helps with venous return and actually aids the ability for the baby to have a higher placental transfusion, which enables better circulatory transition. The difficulty for us is, if you read the literature, there hasn't been much in terms of either randomized control trials or I would say very high quality evidence that's translated into that efficacy demonstrating itself in babies. There's one study which I'll talk about in my next presentation. My view would be, I mean, where possible, I think if you're communicating effectively and you have a standardized protocol, you should practice timing-based cord clamping until there's more evidence at this particular point. And we practice timing-based cord clamping. We haven't yet transitioned to physiology-based cord clamping, though centers in Liverpool and Burnley, slides which I'm going to show you, have done that.
Okay, thank you very much. I have a second question now. For the cord milking, do you have like an evidence, like how much it would equal in term of time of delay cord clamping? So I mean, if I do cord milking, is it equal to 30 seconds of delay cord, or equal to 1 minute or 2 minutes? Do you have an idea, like in the term and the preterm, do you have an idea about that? Or
so what I would say is that we don't practice cord milking in situations where, say, for example, it's been practiced, you're kind of using in the context of a baby, say, for example, who you're worried about, who you can't resuscitate, to actually allow transfusion to take place, say if the baby's not breathing. Now, I'll be really honest to say, I don't know of any literature which equates the volume, but I do know that the volume of transfusion with cord milking is higher. And there's at least one study which has been done by Heike Rabe, which shows that the volume of transfusion is higher, but I can't quote the actual values. The problem with cord milking, as I understand it at this particular point in extremely preterm babies, is the risk of excessive transfusion causing significant rise in pressure preload to the right side of the heart, which then translates into, say, for example, increased cardiac output. But cerebral perfusion might be affected. There's a worry about causing intraventricular hemorrhage in extremely preterm babies. So at this particular point, our standard recommendations are not to practice it in our setup. I'm curious to know, are you practicing it in your setup?
no.
And have you seen it?
I always worry about the amount. What the evidence, and I know from the Canadian experience, that cord milking is kind of bolus. You're giving a bolus. And in neonatology in general, you need to avoid boluses, whether it's a dextrose bolus or normal saline bolus or transfusion bolus, or because bolus is causing lots of hemodynamic decompensation, and the child needs to, you need time to restabilize him or herself. So delay cord, cord milking is not practiced in my experience. Unless further evidence, although the evidence say they are good and they are equal to cord transfusion. The problem, they are bolus. It's not like the delay cord clamping where you give time to the fluid. And also the delay cord clamping will enable the baby to breathe. It's not a matter of giving blood, but you need to give that preload while the baby is breathing to help the transition, not just to give a fluid and let the baby deal with it. So I do not practice it, and I don't know whether I can recommend it or not.
at this stage, we don't practice it either. And we've held off recommending it because I think of the worries that you state, that, a bolus of blood, increased circulating volume very suddenly results in an increase in arterial blood pressure. And that increase might actually trigger risks at the level of the germinal matrix. So, we're practicing delayed cord clamping. I think my clinical bottom line about it is that a physiology-based approach is something that we're moving towards.
Yeah, I agree. Any question? Do you want to go to the second session, or you want to have a rest a little bit? You still have a few minutes for rest for the next session.
Yeah, very happy to entertain any questions while I set up.
I don't have questions yet. People, if you want to have a question, and you can unmute yourself and ask questions, or you can text me and I will say your question. If you don't have a question, I guess it's a good time to have some rest, few minutes before we start the next session. Yeah, you can ask your question. Go ahead. You can unmute yourself, Dr. Yaman, and ask the question, or you can text me and I will ask.
Yes, Dr. Yahya, good morning.
Good morning.
Okay, for the preterm baby resuscitation, baby born with good Apgar score, baby is crying. Do we need to keep on applying PEEP as long as baby is breathing spontaneously? Thank you.
So, what I'd say to that is that the more preterm the baby, the more immature it is. And I think what I'd say is most babies above 32 weeks, 80% to 90% of them will actually breathe spontaneously, and a significant proportion of them will get away without need for actually giving them any kind of resuscitation. They might need a little bit of oxygen. Once you're kind of in the situation where you're under, I would say, 30 weeks, the babies will need some help. And what I would say is that some babies from our perspective will need PEEP, but as this baby settles and as it transitions, heart rate and oxygen requirements actually come down, it may become obvious to you that the baby has no work of breathing. And a good example is a steroided, so an antenatally steroided baby who, say, for example, has enabled and transitioned well, may need no respiratory support, 30 weeks. But I would say that once you hit 26 weeks and below, there is a real risk that if you discontinue PEEP, that you will end up with PEEP failure. And one of the crucial aspects of doing non-invasive ventilation and good work from our quality improvement strategy of providing delivery room PEEP is that you never lose your PEEP for babies under 26 weeks. You never lose your interface because actually when you start resuscitation, you will inevitably have an interface change from mask-based PEEP to delivery of CPAP in the neonatal unit. And if you lose your PEEP in situations like that, in a baby who's breathing as well, what will happen is the lungs will collapse and you will lose your FRC. So it really is related to the immaturity of the baby. The more immature, the more preterm the baby, the more you are going to need to continue your PEEP in order to prevent PEEP failure and the need for intubation. And I mean, to give you an idea, if you look at the support trial, which had an arm of babies where they kind of supported the baby with CPAP, under 28 weeks, about 60% of babies in the range of 26 to 28 weeks needed intubation. But under 26 weeks, 85% of those babies eventually went on to need intubation surfactant. So again, I would say to you that, the preterm babies have a spectrum. And, for babies 30 to 32 weeks, they may well come off PEEP and need no support. But I think for babies under that, you're best carrying on with the PEEP until you're absolutely sure that this baby has made a physiological transition. Does that answer your question?
It's clear. Thank you, Doctor.
Any more questions? If there is no more questions, then probably we still have time, Dr. Alok. Do you want to have a rest or you want to start?
I'm happy to start. Very
Yeah,
happy,
go ahead.
unless the candidates want to rest. Very happy.
I think you can start, and probably we'll have more time at the end for questions. Go ahead.
So what I'm now going to talk about is, we've talked about the physiology, but what I'd like to talk about is the principles and practice of preterm resuscitation and how we apply that. And my focus is going to be some of the differences between the guidance that we practice in the UK versus the guidance that is practiced in the States, which is the NRP. So we follow the Neonatal Life Support Guidelines. But the overall learning emphasis is going to be on a standardized approach, which both these guidances emphasize in preterm care. And that I call is the DTABC approach, which kind of means delayed cord clamping, thermal care, airway breathing support, and circulatory transition. We'll also talk a little bit about special circumstances during preterm resuscitation where practice might differ. Now, what I am going to emphasize is that if you look at the differences between our guidance, which is the Neonatal Life Support Guidance, and the NRP, I'll be really honest to say that there is very little. Both of them focus around keeping the baby warm at birth, use of a thermal care mattress or a plastic bag to do that. That is preceded by delayed cord clamping where possible and permissible. But they all talk about aerating the lungs by giving positive pressure ventilation for the non-breathing baby, or PEEP for the baby who's breathing. I think the difference that we have with the Neonatal Life Support Guideline in the UK is we start with what we call our 5 inflation breaths. Now, please be aware, this is not sustained inflation, which I'll talk about subsequently. These are what we'd call low, long eye time inspiratory breaths, which we provide to babies, which are about 3 seconds. And from our perspective, we provide 5 of them. And the principle behind providing these breaths is that you allow inflation of the lungs to redistribute the fluid that's there in the alveoli, push that fluid into the interstitial space, aerate the alveoli, and establish that FRC. And once you've created that and the heart rate has started to come up, or you have visible chest wall movement, then you're in a situation where you can go to normal ventilation breaths, which is the 2-second breaths. If I look at the NRP algorithm, they espouse a similar principle without using the longer eye time inflation breaths. And I'd be honest to say that I think both of them work. And there's no actual evidence to say that any one method is better than the other. What I would say to you is that when you apply resuscitation algorithms in conjunction with what the ILCO recommends, is we have the knowledge, we know the practice. The question is, do we really apply it? And one of the aspects that, if I have time, I'd like to share with you is the importance of the human factor approach, where what you have to do is have the ability to be able to prepare everything, standardize your teams, standardize even communication, so that what you can do is understand that what you're actually doing is applying these algorithms, and you are unconsciously competent at being able to do that, is the word I would like to use. If I talk about those algorithms, they're a little bit generic. And the reason they're generic is they're meant for resuscitation of both term and preterm babies, with additional modifications that are provided by more preterm specific guidance. And again, the guidance that we would use in the UK is basically the European consensus guidelines that help us, I would say, individualize management to the more extreme preterm end of the spectrum of babies, where what you do have to decide is you might provide the breathing baby with PEEP, and you might be able to recruit alveoli, but some of these babies will eventually need surfactant. And the question then is how you determine which babies need surfactant, how you actually administer surfactant, but more importantly, how you optimize outcomes. And in keeping with the DTABC approach, what I am going to talk about in this session is give you an approach to preterm resuscitation or stabilization, which focuses on optimizing their outcomes. And what is crucial is that when you resuscitate any extremely preterm baby, if you resuscitate them in a standardized way, individualizing your approach to that baby, what you will be able to achieve is good thermal care with a thermo-regulated outcome, which enables normothermia, lung protective ventilation, whether you have to provide PEEP, IPPV, or intubate and product surfactant, give surfactant to this baby, and enable transition with circulatory stability. The overarching aim of all of this is to enable neuroprotection, which results in what I would say is our outcome of intact survival. So what we want to do at the end of this resuscitation is provide the groundwork for a baby who does not have early or late complications, because what we know is that if we don't use a lung protective strategy, we give too much pressure, or we ventilate those lungs very hard, we will damage them, and we know that that will lead to chronic lung disease. But more importantly, if we're in a situation where we say, for example, use strategies like, say, for example, cord milking, we might give too much, and that might lead to an IVH. But more importantly, if you allow this baby to become hypothermic, and this baby develops an IVH because it's hypothermic, all your resuscitation practice eventually results in a poor outcome. So what we want to do is focus on TABC, but with a view to using all these strategies in unison. To start off with, the recommendation as part of our standard resuscitation guideline, the neonatal life support, is that if we have a preterm baby and we can keep that baby warm, what we should do is pause for at least a minute to allow placental transfusion. What is critical is that we're assessing the baby very carefully for breathing support. In my mind, this is a time-based delayed cord clamping strategy. What we are now transitioning to is what we call a physiology-based preterm stabilization strategy that allows delayed cord clamping along with ventilation simultaneously. Now, this apparatus that you can see next to the baby here is what is called the LifeStat trolley. There is another trolley which is called the Concord, which is being developed and used, which is also being widely stated, which is being adopted for practice. Now, this is an elective cesarean section. You can see the baby being delivered over here, but what is happening is the cord is intact. The team have communicated, and you're initiated PEEP alongside the baby. The baby can be kept warm on this trolley, which actually delivers warmth through conduction while keeping the baby in the plastic bag. So this is a delayed cord clamping strategy that uses ventilation simultaneously. On the other hand, we unfortunately, at the moment have not used the LifeStat trolley. And the reason we haven't used it, because it's quite an expensive piece of equipment. So it costs in the range of about £15,000. Now, our problem in our setup is we have 14 labor ward rooms downstairs. We have 4 theaters. We have 2 floors upstairs, which have up to 34 beds. Now, the question is, where do you keep one LifeStat trolley? You need multiple LifeStat trolleys in that situation because preterm babies can deliver anywhere. So it has to be taken. The other aspect to it is a lot of preterm babies occur imminently without actual notice. And, having a single LifeStat trolley doesn't necessarily solve that problem. However, what we also have noticed is when we used it for a trial is that because it uses predominant conduction in order to keep the baby warm, thermal outcomes for babies when we practiced this process were poor. And in particular, if you look at the plastic bag, the concept of keeping a baby warm is keeping that baby in the plastic bag with the head covered in the center of what I would say a radiant warmer right under the heat source, which causes the moisture on the baby to evaporate and creates a humidified, warm environment. Conduction does not produce the same effects. Now, people have basically worked around that by providing thermal mattresses, and the NRP does talk about the use of thermal mattresses. So that's one way to kind of work around that. And it's a practice that's been used by my colleague, Dr. Shihab and Dr. Amitav Asur in Burnley, from whom I've borrowed these pictures. So I'd like to acknowledge their use. Our strategy for delayed cord clamping is the strategy that you see over here. So this is a baby being delivered in theater at 24 weeks of gestation. And what we will have is we'll have a baby who's, a member of the team who's padded up and sterile, who has got a thermal care mattress, which is wrapped in a sterile sheet. As soon as the baby is born, the obstetric team will initiate a process of communication where they assess whether the baby's got breathing efforts. They can touch the cord to see whether there are pulsations in the cord. And if they feel that that baby is showing breathing efforts and is relatively with a good heartbeat, they place it in this clean, sterile environment and allow 60 seconds of delayed cord clamping to take place. What this enables us to do is also start stimulating the baby. We do not clean, wipe, or dry the baby during this period, but actually while you're keeping it on that sterile sheet, you can start stimulating the baby, and that actually stimulates the baby to breathe. And actually, as we discussed, and the reason for showing you those slides on physiology, what is really important is that you're initiating breathing in these babies, and there is actually good evidence, even in human studies, to show that initiating breathing at this stage, where it might not be possible to deliver positive end expiratory pressure or inflation rates because you lack a sterile surface, is beneficial. What is difficult from our perspective is it does mean that babies who, say, for example, are at risk or need resuscitation, a good example is a baby who might be having fetal bradycardia, say, for example, or say, for example, a baby that's not breathing or has a low heart rate, miss out on the ability to be able to get delayed cord clamping because we can't resuscitate and initiate ventilation. And I completely agree with Yahya that actually these are babies who actually would benefit from a placental transfusion, because actually if you give them the preload and you're initiating ventilation for them, you are actually supporting the ability for their placental transfusion to take place by inflating the lungs, aerating the lungs, and allowing for a drop in pulmonary vascular resistance, which accommodates that placental transfusion. Now, that approach is a time-based approach, obviously from our perspective. And this approach of ventilating babies simultaneously to stabilizing them and allowing delayed cord clamping has been studied by Anup Katharia. They looked at about 130 babies randomized to two arms, one arm which had routine delayed cord clamping alone, and the other arm which had initiation of resuscitation alongside delayed cord clamping using the life start trolley, as I've just shown you, along with a thermal mattress to keep the baby warm. Now, I'm going to be honest to say this is a very small study with very, very small numbers, and experience would say that while they did not demonstrate any significant differences in hemodynamic status or hematocrit, nor did they demonstrate reductions in mortality and NEC, I would still say that physiologically, that is the way forwards. And actually what we really need is we need larger multi-center randomized control trials to actually demonstrate the benefit of what I think is going to be the future of how we manage delayed cord clamping. I think a crucial aspect in this study that I would like to elucidate is that this study used a lot of echocardiographic parameters in the early hours to actually measure both the left ventricular and the right ventricular output. And I think that is a very crucial aspect of trying to do studies on delayed cord clamping and ventilation to be able to demonstrate the benefits of placental transfusion and the impact on myocardial function in particular. If we look at the steps of delayed cord clamping as we practice it, so whenever we practice delayed cord clamping in our setup, whether vaginally or with cesarean section, especially in extremely preterm babies, we have a huddle where we discuss how we're going to do it. We have a team of individuals. So this is the obstetric team. And we have an individual who sits besides the baby in a sterile environment. And there's very close key communication. And a good example is if the mother suddenly starts bleeding because there is excessive blood loss, or if we find that the mother has suddenly become unstable, then actually what we can do is we agree to clamp immediately, and that means the obstetricians will clamp, and that allows us to take the baby to the resuscitator. And experience says that that communication is absolutely crucial when you're initiating dermal delayed cord clamping along with thermal care. Thermal care. Now, this is something that I'm passionate about. And the reason I'm passionate about this is because I'm going to give you an example to say that I work in a tertiary center, Southampton, which is a tertiary center which has about 100 babies that deliver under 32 weeks of gestation. I'd say about 70 to 80 of these babies are under 30 weeks. And about 65 to 70 of these babies deliver under 26 weeks of gestation. Now, I'm going to say to you that in 2011, when we looked at admission temperatures for babies delivered under 30 weeks of gestation, 1/3 of our babies came to us with a temperature under 36. We obviously, from our perspective, are not proud of that statistic, but what we did is we've implemented a lot of quality improvement strategies. We were already using plastic bags at that time, but one of the aspects of care that we've introduced into our newborn resuscitation practice for extreme preterm babies is we will measure temperature during resuscitation. And what you can see here is that not only do we have a saturation probe attached to the right hand of the baby, but we've attached a thermal probe into the axilla of the baby, which is monitoring this baby's temperature using servo control, which we set to 37 degrees. The baby is then wrapped in the plastic bag and put right in the center of the resuscitator. More importantly, I would say in certain specialized circumstances like delayed cord clamping, if we can't initiate this process from birth, our obstetricians will put the baby in a sterile plastic bag, which is called a Neonatal, which you can put the baby in and zip up. And actually that covers the baby, keeps it in the moist, humidified environment for it to come onto this sterile surface. And using strategies like this, I'd just like to say to you that in 2018 and 19, we did not have a single baby with hypothermia coming to the neonatal unit under 32 weeks of gestation. So what is crucial again is we know this, but do we actually implement it? And this is an example of a baby who in my practice is receiving good thermal care. So you can see the plastic bag is right up to the neck. The baby is completely inside the resuscitation plastic bag. Its head is covered. Can anybody give me any mistakes that have happened in this? So I'm going to open this to the audience. So do you see any problems here? Can everybody hear me?
Yes. The oximeter is not, I can't see it, and I think we need opening for that.
Yes.
Also the clamp, it's called material. I mean, the Caesar is called, I guess, and should be maybe also a little bit out or removed. I don't know. This is what I see odd only.
Very sharp. My compliments, my compliments. So what you can see over here is this cord clamp is inside. Now you can imagine, I want this baby to achieve a temperature of 36.5 to 37.5. Now that's metal. If that heats up to the same temperature, can you imagine what that's going to do to the fragile skin of a baby? So again, when I talk about human factors and the approach to resuscitation, we're kind of in a situation where a lot of people like placing babies so that they go into the plastic bag with the head first coming out the top. But we practice a different strategy. We fold our plastic bags up, and actually before the baby goes into the plastic bag, one member of the team will apply the cord clamp and take this metallic cuff off, simultaneously to putting a hat on. Baby goes into the plastic bag and we roll the plastic bag over the baby. And our experience is that actually when you do that, you're more likely to get the plastic bag right up to the neck with a temperature probe that goes into the axilla. And actually, once you've done that and you set it to servo at 37, you rarely need to actually worry about temperature in our environment and our setup. More importantly, what I'd like to show is this is how it happens simultaneously. So the baby is brought to our resuscitator. Now you can see here that this baby's gone into a plastic bag. It has a SATS probe applied to the right hand. It's also got a temperature probe which has gone into the axilla. It's got a nettelast hat, which again helps to keep the moisture in the head. But what we're also doing is putting a woolly hat. So that's the nettelast hat there, and that's the woolly hat that's going on. PEEP is being applied simultaneously to this, and assessment is happening simultaneously. So what we are ensuring is that this baby does not lose its FRC. that we have a dedicated person who's looking after the airway. And this person who's looking after the airway is usually the person who brings the baby after delayed cord clamping. And his job is to maintain the seal, not lose the seal, maintain the PEEP, and keep that seal throughout resuscitation while we are assessing the baby. It is the nurse's job to keep an eye on the temperature. We have a temperature monitor which tells us temperature is, and it is the circulatory person's. The next key step in resuscitation is lung inflation. And we've talked about how fragile the lungs are. If you overinflate the lungs, that leads to inflammation. And there's good evidence from studies to show that babies who obviously are resuscitated aggressively, in particular babies who are intubated, ventilated at birth, tend to have higher interleukin B levels, which correlate with long-term inflammation and sow the seeds for chronic lung disease. What is important is that both guidance from the NRP and our neonatal life support talks about initiating respiratory support if the baby is not breathing, but using gentle pressures of between 20 to 25 centimeters of water. Now, I just would like to say that the NLS recommends using a PEEP of 5. Obviously, this varies, and I don't think from our perspective that's set in stone. And there are some babies where you have to individualize, and some reasons would use higher PEEPs, and I have no qualms or anything against that. But what I would say is that what is important is that if you're delivering this ventilatory strategy to inflate and aerate lungs in a not breathing baby, a TPEEP delivers more sustained pressure in terms of both peak inspiratory pressure and PEEP as compared to a self-inflating or a flow inflating bag. Once you've inflated the lungs, our strategy and approach is then to give ventilation breaths, which are short eye time, 2-second breaths, and we try to give them at 30 per minute. But what is absolutely crucial is if we're using pressures of 25 and you see a chest that's bouncing, that you very rapidly start weaning that peak inspiratory pressure, because what you're actually doing is you're damaging those lungs. If you look at the recommendations for lung inflation, as I've discussed, a TPEEP provides more consistent and a predetermined level of PIP and PEEP. Self-inflating bags and flow-inflating bags can be used. There are now self-inflating bags that come with PEEP valves. I think the worry that we all have is they do not deliver sustained PEEP in an effective manner. We've talked about this, so I'm going to skip this slide. I think the one thing that I would like to say, and going back to this slide over here, is if you're delivering positive pressure ventilation, it's really important that you're considering an appropriate size mask, keeping the baby's head in neutral position with a good seal. And just coming back to that concept, too much pressure of your hands on the baby's face will compromise your ability to be able to give good inflating breaths. And the reason for that is you mold the baby's face, A, so you actually make your mask leak worse. You actually mold the mask. But B, remember the trigeminal reflex. You stimulate pain, you cause glottic adduction, and actually paradoxically in situations like this, the baby's glottis will adduct and you will not be able to inflate and aerate the lungs. So again, absolutely crucial that from a human factors approach, you're using all of these things to actually enable lung inflation. Now, one of the things that I talked to you about was slightly higher eye times with lung inflation. And a concept that's been espoused in practice is sustained lung inflation. And to be honest with you, I'm going to say to you, I think there is definitely a place for it. I think the question from our perspective is whether we need more studies to look at what the appropriate duration of sustained lung inflation is and how that might individualize to different groups of extremely preterm babies, especially with subgroup analysis of babies. So just to talk about sustained lung inflation, traditionally sustained lung inflation has been defined as long eye time inflation breaths that are provided to preterm babies, which allow for continuous inflation of the lungs without a disconnection of the mask while providing PIP continuously for durations of up to 15 seconds, once or twice. And the Cochrane review at this particular point, now if you look at this, talks about sustained lung inflation, looking at studies which use such a strategy. So this is a slide courtesy Dr. Stuart Hooper from the Ritchie Center in Australia. And what it clearly demonstrates is a sustained lung inflation and in a baby that's initially not breathing. And what this helps establish is breathing in a baby by establishing an FRC. And you can see how well the lung inflation causes inflation of the lungs in this rat pup. But what is crucial is that it is sustained, it is uniform, and it allows the inflation of both lungs in a very coordinated, uniform manner. And animal studies have definitely been able to demonstrate that actually when you use sustained lung inflations of the durations that I've just described, that you are able to achieve more uniform expansion of both lungs, better alveolar recruitment, which then translates into a better FRC and establishment of tidal volumes. I think from our perspective, the question is, has this actually translated into good outcomes in clinical practice? And I'm going to talk a little bit about the SAIL trial, which was conducted by Harish Kripalani and his group. And they looked at sustained lung inflation involving very long I-time inflation breaths delivered to a group of preterm babies, 23 weeks onwards, and the impact of that on the risk of bronchopulmonary dysplasia and death at 36 weeks. These inflation breaths were long I-time inflation breaths delivered at a pressure of 25 for 15 seconds, where a first breath was delivered while the heart rate and breathing were being analyzed. And obviously, if there was no response, a second sustained inflation was delivered in one group, while conservative normal practice of provision of IPPV or PEEP was practiced in the other group. What was really interesting is that when they analyzed and did subgroup analysis, they found that actually there were no significant differences in either the risk of bronchopulmonary dysplasia or death at 36 weeks. But there was a real worry that sustained lung inflation was associated with some concerns with regards to obviously a longer duration and a higher worry with regards to what it might be doing in terms of cerebral perfusion to the lungs, not necessarily with this study. What they were able to demonstrate was that there was association of sustained lung inflation with a higher success rate compared to the conventional route, with a lower need for delivery room intubation. Also, post-resuscitation interleukin-1 plasma B levels were increased significantly in this. So from our perspective, when we look at the study of Harish Kripalani, well, that looked at the risk of extremely small babies having higher rates of intraventricular hemorrhage. They had to stop their trial because of the risk and the high risk of death in the arm which received sustained inflation. But when we look at a further study of use of sustained lung inflation at a lower pressure, so pretty similar to the pressures that we use in the neonatal life support algorithm. So this is a randomized control trial on 112 preterm infants, not using sustained lung inflation in the concept of long I-time inflation breaths for 15 seconds, but 3 inflation breaths with a maximum pressure of 30 for 15 seconds. So smaller inflation breaths followed by continuous positive airway pressure versus just conventional bag and mask pressure. They were actually able to demonstrate that you achieved a higher success rate of sustained lung inflation, lower need for delivery room intubation, and a lower inflammatory cytokine release. So I think what we need to contextualize is the fact that if you're using sustained lung inflation with very long I times and for longer durations, there is a concern that you might actually be reducing venous return to the right side of the heart because of the high pressure in the chest, which again reduces preload and then reduces afterload because of reduced pulmonary blood flow, reduces venous return to the left atrium, which compromises cerebral perfusion. And there's a risk in that situation that you might actually cause IVH. But if you were to look at using sustained lung inflation, say in shorter durations, and maybe for a group of babies, say, for example, who are not so extremely preterm, you might have better effects. And I think at this particular point, the clinical bottom line of the Cochrane review is that a meta-analysis of 9 studies did not demonstrate that sustained lung inflation was any better than intermittent ventilation for reducing mortality in the delivery room. I think what I would say is that we probably need more studies with shorter sustained lung inflation times, maybe less pressure. And we need to look at specific subgroup analysis of extremely preterm, moderately preterm babies to kind of determine which babies we think will benefit from it the most and what side effects it actually has. I'm now coming on to the next aspect of resuscitation, which is what we do if the baby is breathing. And I think a key step from our perspective is we would initiate delivery room PEEP. Now, I think what I would like to say is that there is a difference between the terminology of CPAP in the delivery room and PEEP in the delivery room. And that what we deliver in delivery suite is PEEP. What you deliver once you transport a baby to the neonatal unit is CPAP. In terminology, a lot of people equate that with the same things, but some people believe they're different. I think eventually what we're trying to do when we give PEEP is establish FRC, just like you would do when you give ventilation beds. But there are other advantages that you are able to see. So a continuous CPAP provides continuous airway pressure, sustained volume in the lungs. It decreases airway resistance, improves lung compliance, reduces apnea, improves oxygenation. But what has been seen in animal studies, it actually improves recycling of surfactant and conserves surfactant. But also, again, animal studies have shown lower release of cytokines, which might actually be implicated in the development of chronic lung disease later on. So if I talk to you about the PEEP in delivery suite, so this is a rat pup who is having ventilation delivered with no PEEP. And what you can see is the alveoli are completely unstable. They tend to collapse quite easily. On the other hand, this is rat pups delivering or receiving ventilation with a PEEP of 5. And what you can clearly see is that when we talk about establishing functional residual capacity, you can clearly see that when you use a PEEP of 5, the duration, and this is duration, seconds. So the time to actually establish functional residual capacity is much, much better in terms of both the volumes, but the time taken to achieve those volumes is much quicker. So there's absolutely no doubt in both animal and human studies that actually the use of PEEP at birth has significant benefit. If we translate that into impact on chronic lung disease, then there is a meta-analysis that's been done by George Smolger, a colleague of mine in Canada, who has done a huge amount of work in this regard, which actually shows that use of PEEP in studies done by Dawson, Feiner, and Gilles actually favors a lower incidence of chronic lung disease versus when you don't use PEEP. A key question that you might want to ask me is, what should we start with? And I'm going to say to you that actually there are no high quality studies that actually demonstrate that a PEEP of 6, 7, 8, or 9 is any less or any better. I think what I would say is that our guidance is to start with a minimum PEEP of 6 in delivery suite. And this differs from the neonatal life support guidance. And I would probably say that most extremely preterm babies, a PEEP of 5, if you consider the loss of seal, the loss of, transfer of PEEP through apparatus like delivery circuit, the resistance in the delivery circuit that connects to the PEEP circuit. I think a PEEP of 4 is completely unphysiological, but a PEEP of 5 probably loses a lot. And I would recommend that we start with a PEEP of 6 and titrate that PEEP depending on work of breathing and obviously the oxygen needs of a baby using saturation monitoring. A key next question that I'm very passionate about is how much oxygen to start with and how to titrate. So I'm just keen to throw that open to the audience. So how much and what FiO2 do you start with? And I'm talking about babies under 26 weeks.
25 to 30%.
Okay, and how do you titrate that? So
up or down according to the saturation. the baby SpO2 and the response actually. When we go to active resuscitation, the habit is to increase directly to 100. But when the baby heart rate above 100, then we decrease also fast. We keep the saturation 85 to 90. We are happy with that. And the lowest we can use of FiO2. This is what the trend is, not to give a lot of oxygen.
Okay,
But
fantastic.
we start 30%, 30 and below the start. Then according to the baby respond, we manage.
Okay, so what I'm going to do is I'm going to give you a little bit of a recent evidence-based approach based on current studies, which take into account the physiological principles that I've just spoken about. So I would agree that where possible, use a pulse oximeter and where possible ECG in order to monitor both your heart rate and the saturations. And I can't emphasize this enough, that actually the response to oxygenation, a lot of people talk about just monitoring saturations, but actually heart rate is probably just as important, in that there is evidence, emerging evidence now to show that actually if you are trying to resuscitate babies and if you lose too little oxygen, their ability to respond in terms of a rise in heart rate is impaired. I think the question from our perspective is how much oxygen do you start with and how you titrate? Now, I'm just going to take you through a little bit of the history. And up till 2005, the ELCO recommendation, even for preterm babies, was to start in 100%. But what actually became quite obvious from work done by Ola Sokstad and my guru, Dr. Siddharth Ramji in Delhi, who actually trained me, was that when you resuscitate both term and preterm babies with 100% oxygen, not only are you causing a huge amount of free radical release and oxidative stress, but those free radicals stay in the baby's bloodstream up to weeks, up to 6 weeks after you've actually started the resuscitation, and they actually cause lung damage. So there is evidence to actually show that when you resuscitate in 100%, preterm babies actually have oxygen toxicity, and those toxic effects, not just on the eyes, and a lot of people have talked about the risk of ROP, but actually what I'd say to you is there is also a risk that you are causing damage through free radical injury to the alveoli. Well demonstrated in animal studies. I think the key aspect is how do we balance the risk of giving too little and too much, and where you start. So there are observational studies, and when we looked at the resuscitation principles applied to term babies, after 2005, a lot of centers went down to starting resuscitation in air alone. And there were then observational studies which were published in the second decade of this century, which raised concerns about starting extremely preterm babies in air because of the risk of bradycardia. And the worry, obviously, from people was that they noticed increased mortality in extremely preterm babies, and in particular in babies under 26 weeks of gestation. And this is linked to prolonged bradycardia and an association both with intraventricular hemorrhage. But I think from our perspective, the other worry that we have is there is a recent study which has actually demonstrated, so that's the torpedo trial, that a failure to achieve a combination of a heart rate above 100 and when it's associated with lower saturations, especially if this is within the first 5 minutes, there is a higher incidence of death and intracranial hemorrhage in babies under 28 weeks. Now, these studies and the work done by them has obviously made us worry about air alone. And I would say to you that we have looked at further studies, and there's work that's been done by Wang, which looks at resuscitation of babies randomized to air or 100% oxygen in conjunction with ventilation. And I think their worry, albeit very small numbers, was that there were babies who, say, for example, had prolonged bradycardia and lower SpO2 in the first 5 minutes of life when they started resuscitation in air. And a significant number of them then had to be switched to the 100% group in order to get them saturating. If we take all of this into account, I think there is a significant concern that using air alone predisposes babies to lower heart rates. But in addition to that, you need a certain amount of oxygenation in order to stimulate breathing in apnea, and that hypoxia depresses the respiratory centers. And there is a piece of work which is looked at resuscitation by Decker et al., which has looked at resuscitation of babies in 100% oxygen versus babies in 30% oxygen, with babies being titrated down in the 100% group versus the babies in the 30% group. And what they noticed is that when you resuscitated babies with 100%, obviously using saturation monitoring, they had higher minute volumes, a shorter duration of mask ventilation, higher oxygenation at 5 minutes, and a shorter duration of hypoxemia. Now, I think this study has very small numbers, but again, it raises the concern we have about starting babies with too little oxygen. By no means does it imply that we should start resuscitating babies at 100% oxygen. I've already spoken about this. I think if I were to summarize, I would say that there is low quality evidence that we should be achieving a heart rate above 100 and saturation of about 80 to 85% at 5 minutes of age, 85 to 90% at 5 minutes of age. And that there is also concern that if we use too much oxygen, we will be causing free radical injury through hyperoxia. So actually starting somewhere between 21 to 30% and titrating up might be the way forwards. Now, the question is, obviously, if we want to achieve this heart rate and these saturations at 5 minutes, how quickly we should do this. And I think at the moment, there is very little in terms of evidence or studies which actually look at strategies, timelines. A pragmatic approach is to use Dawson's data. Now, this is work that was done on I think about 400 odd babies, but had only 39 babies in the preterm group. And they've looked at increments, and what they've talked about is looking at achieving 25th centile, but also using and starting with 30% oxygen in extremely preterm neonates to try and achieve a heart rate that nears 100 at 5 minutes, or saturations of 85% together. Obviously, wean saturations if you achieve higher centiles during this period. Now, another question to you. What has not been looked at in studies is you start a baby on PEEP. It's a spontaneously breathing baby. You start in about 30% FiO2. This baby is 25 weeks. It's not achieved its saturations, and it has significant work of breathing. So would you increase FiO2 or would you increase PEEP? I'm just curious about your approach.
PEEP.
Okay. The baby is spontaneously breathing.
I mean, increased work of breathing, that means the baby has still his alveoli not open, and this is why he is retracting. So what the benefit from the oxygen in this case? You need to establish the FRC and open up his alveoli. This is what we need. So I think the PEEP is the one important.
Okay, so it just highlights the difficulties we have with new emerging evidence, which actually talks about the risk of hypoxia, impact on the larynx and glottis, and impact of hypoxia on breathing. Because actually there is a kind of, I'd say, opposition between the need to provide higher PEEP to establish FRC, but the lower oxygen causing a lack of drive, which might be contributing to this. And I would say that this is where we need to start looking at randomized control trials. I think I would probably agree with you that my own practice would be that if I have significant work of breathing, physiologically I'm hoping I've established enough oxygenation to stimulate breathing because the baby is breathing. So in that situation, if there's work of breathing, recession, grunting, actually PEEP in my mind would be the plausible option because I want to improve the FRC, improve alveolar aeration in order to stimulate and minimize work of breathing. So I would start titrating PEEP upwards from 6 onwards to try and work on that work of breathing. I think if my saturations were below centile, I wouldn't hesitate to go up by 20% at a time, and I might use both simultaneously. I think it's a real challenge in that situation to kind of say, how you manage those opposing influences. I think without a doubt, and I'm going to skip through these slides with the time factor, in that the question from our perspective is, do you continue CPAP? What about prophylactic intubation? So can I ask you another question? Would you ever prophylactically intubate any preterm baby? Or would you always start with CPAP or PEEP?
No, we start with CPAP, definitely, at least few minutes to see. And then we decide. But for example, 24-weeker and below, unlikely they will be happy with the CPAP alone. So sometime really we especially mother, most probably she didn't receive betamethasone and there is bad obstetrical history. So most probably really we intubate before even the baby breathe. But we are speaking now 25, 26 weeker. Yes, we start with CPAP and we give some time. We see what the baby is doing. Some of them really are good and they can tolerate somehow. But especially if the mother have already the cortisone, magnesium and all these things, we give a chance, but not long a chance. I mean, if the baby working hard and the FiO2 requirement increasing, the PEEP will reach 8 and FiO2 we are now 50-60%. Yes, we intubate in the MDU or OR and we give surfactant that time.
Okay, so
Can I comment?
Yeah, please, please. Yeah, please.
Okay. Well, first, I don't agree with giving surfactant at resus room. I don't think surfactant is an emergency medication. I think surfactant should be given in a stabilized situation. That's one. The second is I would be hesitant to make decisions on the term work of breathing because obviously this is subjective. And the third one is I think that all the babies, regardless of the gestation, even if they are 23, they worth trial of CPAP. And if the CPAP was done properly and give them time, the most of them, they recover. The other point, the resuscitation are pillars. And I would say that 50% of intubation needs at resus is not due to the need of FRC, it's probably need because of the breathing. So giving caffeine, controlling temperature and controlling sugar would reduce, in my opinion, would reduce much of the need for intubation. Sorry for that.
No. I think I completely agree with that premise, in that even the smallest and the most preterm babies, I think, really benefit from our perspective with the ability to be able to receive either PEEP, or if they're not breathing, I think what you need to do is you need to initiate lung inflation with mask-based strategies because you want to establish their FRC. And I worry about the circumstances of prophylactic surfactant, because actually, if you give a tube into non-inflated lungs and you then bag the surfactant down, the worry is you just atelectatic, you haven't established FRC. So the distribution of surfactant in those circumstances is, the question is how efficacious is that? I would also say that I think I completely agree with Yaya that surfactant in itself is not an emergency, and that actually what you really want to do is stimulate the baby, enable breathing, and the wider package of care. Imagine giving surfactant to a baby that's hypothermic at 33 degrees. That's going to cause even more surfactant inactivation. So what is really important is the overall package of being able to establish the ABC support. Now, clearly there is work that's been done by George Smolder, which basically talks about CPAP after birth. There are some babies where I would say prophylactic intubation is still practiced in my setup. And a good example of babies like that are babies, say, for example, who are extremely preterm, but with very prone rupture of membranes. And say, for example, if I've got a rupture of membranes from 16, 17 weeks, my worry in those babies about providing PEEP, especially if there is lung hypoplasia, there's demonstrated anhydramniosis. If I individualize to that baby's care, I would worry about the risk of a pneumothorax. So I'd say, never say never, but my routine practice would be for any baby, no matter how small, no matter what weight, I would almost certainly in those situations start with PEEP or with inflation rates, and I would try to establish that FRC, get that baby breathing, and then try and evaluate whether that baby is going to fail. Now, to bring this talk to a kind of, I would say, close, and I'm not covering Lisa and surfactant delivery as part of this, what I would like to summarize is the overall strategy for neonatal resuscitation using neonatal life support principles or neonatal resuscitation practice is that eventually what you want to do is establish that package of care. And that means that you start with delayed cord clamping, enabling a preload, thermal care, and ventilation, and you do that simultaneously. So you need a team of people who are able to initiate resuscitation simultaneously so that you're ensuring a good thermal outcome along with establishing aeration FRC and the preload, so that these physiological parameters are allowing optimization of the physiology and the homeostasis of every baby in order to maintain and obtain neuroprotection, good cerebral perfusion. And the eventual aim is that we work towards individualizing that approach to each baby. So with that in mind, I'm going to give you a case. So you have, and this is for the trainees. So let's say you have a baby who's delivering at 23 weeks of gestation, and this baby has had a rupture of membranes from 15 weeks of gestation, but has had antenatal steroids and is in a situation where it's bulging membranes about to deliver. How would you resuscitate this baby? And my focus would be the respiratory side, just in interest of time. What kind of PEEP would you start with? How much FiO2 would you start with? How many team members would you take to this delivery?
23 weeks new mother, okay.
Hello?
Hello, yeah.
Yeah.
For us, we go one physician or two with the RT and one nurse. Actually, maybe more than one nurse sometime if we are free and not busy in another resuscitation. This is the team, the preparation. We have the Curacef with us. And when we go, we expect that 23-weeker, most probably he will need Curacef or surfactant. So we assess the baby. We get the baby from the obstetrician team in plastic bag, cap, and under the warmer. Put the prop in the right hand, and we start FiO2 30% with a PEEP 5 to 6, 5 maybe because pulmonary hypoplasia is a worry here. And we see how the baby responds. In that time, if the baby not breathing or breathing, this is important. So if the baby not breathing, PPV started while one of the people preparing for possible high probability intubation and Curacef at the same time. So if the baby continue not to breathe, this is emergency intubation. Intubation will be done and the
Okay. So my question to you is, when would you intubate this baby? What would your criteria be? How do you know PEEP is failing?
It's 1 to 2 minutes. I mean, maximum it should be, not according to the NRP. I mean, you can't leave the baby apneic for a long time, trying to establish things. So it will take you 30 seconds to 1 minute to put the baby in the position to intubate. So this is 2 minutes is, I think, enough to decide that this baby benefiting from your procedures or not. The saturation remain low, like 40s, 50s, and no respiratory effort. This is indication in this case that this baby really not getting either the pressures are not enough. Maybe we can increase little, but not much, because also we don't want to have a pneumothorax in the MDU. This is worse. So I think here intubation is a good option with a gentle ventilation after that. And I believe that Curicef or surfactant, whatever the type, will make a big difference. We do the bagging, we warm our surfactant or already pre-warmed in that time, and we give it in MDU. In many cases, it happened with me, it's within 10 minutes, we are
What is
already
MDU?
done with
Sorry, what is MDU?
the delivery rooms, sorry.
Oh, in the delivery room. And what
Yeah.
is the mean the timetable of surfactant administration? Do you have like that? Like
Yeah,
what is
we
the
are
mean?
done. I mean, when we record our notes later, most probably within 8 to 10 minutes, the Curicef is gone already to the baby, and because we
So you
record
give
everything.
within 8 to 10 minutes of life.
Yes, it will be there already, most probably sometime
When
because the
the
preparation
surfactant will
and
reach the baby. When the
if
surfactant
we,
will reach the baby.
actually, this is if we know that this baby is like this. Sometime, you know, you go first the physician, and then they, you know, you are not expecting the delivery now. So when it's in rush, then the nurse has to go and get it from the NICU, from the store, and so it takes sometime up to 20 minutes. But most of us, we give Curicef in preterm babies in the delivery rooms. And we are happy with that. By the time we are back in NICU with the babies are, most of them, ready for extubation. This is just observational.
You are happy with that. But I'm not happy. I'm actually very upset if people follow what you say.
No, we do that. If the baby needs intubation, we need Survanta. This is the rule in our hospital. If
no, let me tell you something. Let me tell you something.
Weaker, you will not give him, because as I understand that the prolonged PPV and you didn't open yet the alveoli with surfactant, so you are damaging the lung. This is what was happening before the era of surfactant, isn't it? That all the chronic lung disease and the things.
So let's just have a listen to what Yaya is going to say. Yaya, do you want to come in?
Yeah, so we're not arguing or commenting whether the surfactant works or not. What we're commenting is the time of giving surfactant. Now, the evidence said early rescue, not prophylactic. And when we say prophylactic, we mean the time within 30 minutes. So I have a problem with that is that surfactant is not an emergency medication. Second, the surfactant should be given in a stabilized situation. Third, there are many other things more important than surfactant, like the sugar, like the caffeine, like the temperature control, establishing FRC, and so on. So, and the evidence is very clear. The best surfactant is between 30 minutes and 2 hours. So there is no rush to give surfactant, whether it's a Curoserve or Survanta or Bless or Infacel. And and the evidence also said that the effect of low temperature is way more worse than giving surfactant. And so if my point is give surfactant, but you don't need to give it before 30 minutes. And give surfactant, but it would be best to give it inside the NICU, inside a closed incubator, control the temperature, and make sure that your sugar is okay, and make sure that the baby received caffeine before you give. That would be my practice. And we have very low incidence of chronic lung disease. We're down to 10%. So I'm not arguing against surfactant, but I would highly discourage you of giving surfactant in the labor room, and not also highly discourage you of giving surfactant within 30 minutes of life.
So coming back to, I mean, that approach, I think I would agree that what you really need to do is establish FRC. And I think with extremely preterm babies, the difficulty that we have is actually initiating the breeding process and establishing that FRC, and the risk of using surfactant in uncontrolled circumstances is, and you know, a fair bit of surfactant often ends up going down the right main bronchus these days. So I think if I stick to the basics of what we practice at the moment, it is really important to be able to use that package of care, be able to ensure that you've allowed DCC thermal care, and you are supporting and establishing ventilation with lung inflation. in terms of further management of the baby, what is very crucial is preventing PEEP failure. And yeah, I was just wondering, how much time do I have left?
So you have, oh, you already passed the time. Sorry.
Oh, so sorry.
Yeah, it's okay.
So I'm gonna very quickly finish by just showing you a video. And again, this video, basically it's 5 minutes, but what it basically does is it espouses certain principles which avoid PEEP failure. So when you're transporting your baby on PEEP, especially if you are initiating CPAP in your neonatal unit, what is very crucial is you want to prevent these babies failing PEEP. And there are some crucial steps. So we're just going to demonstrate this on our baby. This is a 26-weeker. So you can see the work of breathing much less, grunting much less, saturations have improved, temperature is coming up. This is just at 5 minutes. Temperature's coming up beautifully. So 5 minutes with 36.5. 45 sets, about 90.
The video is a little bit slow, not moving in a normal pace.
So we've been the oxygen down to air. So I'd just like to end by summarizing that from our perspective, what is really important is that if you want PEEP to work effectively in your setup, you need to think about minimizing.
Hello, in this video, we're going to look at the clinical anatomy of the hand and also the fingers. So we'll actually focus on the wrist joint mainly. Now,
I think, as I said, the key aspect to managing resuscitation in these circumstances is managing your PEEP by minimizing interface changes. Simple things like if you're managing a 26-weeker and if you decide that you're going to put on the wrong hat size and PEEP circuit when you transport the baby, all the efforts that you've made in the first 20 minutes of stabilization, they're completely lost. And then you realize that actually you reach the unit and the baby's in 70–80% and is recessing significantly. And actually that's an opportunity lost to actually prevent PEEP failure. So if you really want non-invasive ventilation to work, what you've got to do is work on your team's human factors and making sure you make appropriate decisions, not just about resuscitation right at the start, but about ongoing care right up to golden hour management when it comes onto the neonatal unit. And a good example is if you don't focus on temperature, as Yaya has stated, and your baby comes to the unit with a temperature of 35 degrees, it's going to fail PEEP because hypothermia is going to inhibit surfactant breathing. It's going to cause apnea. And then eventually what you're going to end up is needing to intubate and give this baby surfactant. So it is a package of care by a team of individuals considering human factors, but specifically looking at implementing all of this. And if you can implement delivery room caffeine, feather in your cap, it does bring in the additional need for access. I think if you can do that, it's absolutely fantastic. My own practice is to get these babies onto the unit, and that is usually median time of about 22 minutes. Put a cannula, and the first thing that I like to give these babies where appropriate is caffeine to help them. I'm going to finish. Welcome any questions. I apologize about crossing the time.
That's okay. So you do have a couple of questions from Rula, from Dr. Amr, and from Dr. Habibullah. So the first question from Dr. Zir, Rula is asking you, and probably you've answered part of the question, do you start caffeine and dextrose in the delivery room?
So at the moment, not. I think our worry about doing that in the delivery suite is, again, our ability to keep the baby thermally stable. In that, what we want to do is, as soon as we've got a stable temperature with ABC stabilized physiologically, we wanted to get into a humidified incubator. And the reason for that is, in our setup, it's usually junior members of the team who are going to go for access because they're training, and they may require longer attempts as compared to more senior members of the team. So based on that, what we like them to do is we set up everything for access, including umbilical lines, but we put a peripheral line in as soon as we reach, with a view to placing umbilical lines in a normothermic baby, giving antibiotics. Caffeine will go first, followed by antibiotics where appropriate. And then we finish off with an X-ray and a head scan. So the idea from our perspective is caffeine, and that's a drawback in our setup. It's, most babies will probably get it after 30 minutes of life.
I'm a little bit different from your practice, Alok. We do what we have, we call it, you practice golden hour. We have a timetable.
Yep.
So whether it's in the labor room or it's in the NICU, there is a timetable for starting. So for example, CPAP should be on the baby before 2 minutes of life, not after after or during the delay cord. 10 minutes, the dextrose should hit the baby, and 20 minutes should receive caffeine. And by that time, the temperature, and we do for quality control, is the temperature, the saturation, and the sugar level on arrival is our run. And after we stabilize the baby, and usually between 30 minutes and 2 hours, we give surfactant according to the evidence. So the question from Habibullah is asking, sorry, I did not get the point behind not to give surfactant after delivery immediately.
So I think the most important thing about delivering babies is being able to stabilize their physiology before you give surfactant. And the risk of giving a surfactant prophylactically, it's completely out of what I would say is current practice, because if you give that, you've not established FRC, you haven't inflated the lungs, the baby's still hypothermic, its physiology has not adapted. The pulmonary tree, the lungs are still full of fluid, you have no pulmonary circulation. So actually, eventually from your perspective, what you're doing is you're giving surfactant to lungs that are already fluid filled, rather than to lungs which have an established FRC, where surfactant distribution can be, I would say, more uniform, and where you can allow the baby to be able to be in homeostasis. Now, I would agree that this is more physiological plausibility than high-grade clinical evidence in terms of surfactant may be needed at a later stage. But I would say there's definitely some evidence to state that actually delivery room PEEP and CPAP and its success is associated with lower incidence of chronic lung disease. Certainly, I would say our colleagues in Canada have been absolutely fantastic at being able to bring down both the chronic lung disease rates by practicing PEEP and CPAP, and they have success rates even in the most preterm babies. I think that's something that we're still aspiring to in the UK, but even our practice is not to give surfactant at birth with the first breath within, the first 15 to 20 minutes often. What we really want to do is establish FRC. I think the way we practice our PEEP delivery is still not optimal. I think we can learn from our colleagues in Canada. And, I'm really keen to see how they manage to keep their smallest babies off, because our failure rate, babies in 23, 24 weeks within the first 2 hours, is still about 90%. And I'm not proud of that, but, like as Yaya is espousing, maybe it's to do with the fact that we're not getting our caffeine in, that our fluids obviously take time. And, you need energy, you need caffeine to go in very early in this group of babies. And it's food for thought for a QI project for us.
Yeah, definitely. Dr. Amir is asking you, it's wrong to be, or maybe he's reporting that to me. It's wrong to be dogmatic when you're talking medicine, and I absolutely agree with him. I don't know what you say about that, Dr. Sharma. I don't know whether he's talking to me or to you.
Okay, I I would agree with him that, what is important is practice varies in different places. And it's interesting how babies manage. Despite that, what I would say is we can always learn from each other. And there is so much that I have learned from my colleagues, at work, my nurses, in terms of improving my practice, from being a registrar to being a young consultant to a consultant who's now been working for the last, I would say, 10 years. And I'm still learning. So I would say that I completely agree with that. I think what is important is that what we are doing is practicing evidence-based medicine with current practice, which is individualized to the baby, with that will to learn, with that will to be able to want to improve our practice. And I would clearly say that whether I'm in the UK or whether we're in Canada or whether we're in India or the UAE, there are good practices everywhere that you can imbibe into your practice.
I agree, totally. Dr. Jaffer is asking you, if you have a robust golden hour practice, what is the problem in giving in delivery room? I don't know, I think he's talking about surfactant. Are you talking about intubating babies, not Lisa? Something like that.
So, yeah, so again, what I would say is the question is, you've got a spectrum of prematurity. There are babies born as early as 22 weeks to babies born at 32 weeks. And Lisa is definitely one of the up and coming strategies for delivery of surfactant in delivery suite. But the question from our perspective is, do babies really need surfactant? I think that's the question we really need to answer. We have to define which subgroup of babies we can and I think the other question from our perspective is, it's not about surfactant alone. I would come back to the fact that this is a package of care.
Yes.
And the fixation with surfactant, I would agree that about 80% of babies under, 25 weeks are going to need it. But the question is when. The question is, how do we identify babies who genuinely need it versus babies who we're giving surfactant to because we're failing with non-invasive ventilation? And if we could improve our non-invasive ventilation strategies and delivery suite and the package of care, there are certainly babies who will get away without it. And if they can get away without it, then evidence does show they have less chronic lung disease.
Yeah.
And
Doctor, I would, maybe people misunderstand me. I was not talking about not to give surfactant in labor room, but I was talking on when. So now the resuscitation or labor room is different. Some of the units, they have like really a small NICU in the resus. Others, they don't have that facility. So the question is the whole package, make sure the temperature, the sugar, and the baby is breathing, and you give time for FRC to form, and then you give surfactant. And the current evidence said early rescue, not prophylactic, not late, the current about the surfactant. So you can give it in the, if you have a timetable golden hour, you can give it in the labor room, nothing wrong with that. But remember the whole package, the whole babies. And if you look at the Canadian Neonatal Network, and if you go today and look at 2019 report and look at the Manitoba, where I used to work, our failure rate in 23 weeks is 50%. And our failure rate for 24 weeks is like 30%. So, and our chronic lung disease is only 10%, and we go down sometime to 22 weeks. So what we do is, if you look to our resus room, we keep the baby sometime up to 3 hours in the resus room, but we can provide everything in there. So we have even high frequency jet in the. So it doesn't mean where to give, but when to give. So make sure, remember that surfactant is not an emergency. And second is the baby should be stable enough regarding the temperature, the sugar, and should be able to breathe. So my view is that caffeine is probably has a priority over giving surfactant. So I don't know, what do you say, Dr. Sharma?
So again, what I would say is we're limited by our approach in that we're not getting caffeine in quickly enough. And I would agree that I think the earlier you get caffeine in, it's absolutely crucial in helping the baby breathe central drive. I think I would also agree with Yaya that, there are certain centers that have to bring a preterm 23-weeker down 4 floors through a lift, a long distance. And it might be that those units need and have stabilization rooms. So actually what they will do is they will stabilize in the stabilization rooms, which means the entire package of access, surfactant, and caffeine. And that is a better way of doing it, because actually you can do all of that, stabilize, and then transport the baby. Whereas where we obviously are slightly limited by the fact that we find that quite challenging in our setup, room space. So I think individualized to your situation, but
yes. Dr. Ghalia Al-Shamat is asking you, are you giving caffeine and dextrose in delivery room via peripheral line or via UVC?
So we give our drugs by a peripheral line. I like to get a peripheral line in, and the reason for that is a simple example. If you bring a baby into the neonatal unit and he's hypothermic, you're in a situation where you then start accessing him for lines and he gets more hypothermic. So I think the advantage of putting a peripheral line in those circumstances is you get fluids which are at room temperature going into the baby. You can give caffeine to the baby without the need to be able to, say, for example, access the baby for central access, which needs to be done sterilely in a warm, humidified environment. It also means that you don't have to be in a hurry to do that. And one of the things that we've noticed is that we've had a high incidence of UVC extravasation with umbilical catheters being placed in a hurry, where you've hit the liver, you've gone through, and in extremely small preterm babies, you want to use ultrasound or radiology to confirm the position. So there's a lot more time that's needed in placement of umbilical lines, including umbilical arterial lines, which we'll do simultaneously, with fluids that need to be put up in a sterile way through a UVC. But the question is, for units that have peripheral TPN, you can actually start PN on these babies with caffeine through a peripheral line, and that gives you enough time to be able to place central lines where appropriate. But for babies 28 weeks and above, 26 weeks and above, who are nearing 900 grams, the question is, do they need an umbilical line? You can put a peripheral in, start peripheral PN, give caffeine. They get away without tubing. You might not even need umbilical lines.
In my practice, Dr. Sharma, is we actually start TPN in the labor room, and sometimes we start feeding in the labor room if it's feasible. And as I said, our priority is not the surfactant. Our priority is to set an IV. It can be in the labor room, it can be in the NICU, depend on the setup and the time you need it to move the baby. But also we start dextrose and caffeine. And also there's two things that we consider not an emergency, is the surfactant and the antibiotics. And but sometimes TPN we start in the labor room. That's what usually we do.
That's amazing.
Just a question, please, about back to the case 23-weeker with PROM. How many 23-weeker, 24-weeker you have successfully, giving them, how long you give them the chance, how many minutes in your practice you give them to decide intubation? Because for us in our practice, if intubated, that means he needs surfactant and whatever the type. So how many or what the percentage in your practice you have successfully keeping babies 23, 24 on CPAP and taking them to in ICU, then a reassessment and giving late surfactant in case needed? How many you could succeed with that?
Is this to me or Dr. Sharma?
Both of you.
Okay, Dr. Sharma, start.
Yeah, and in your practice, because I don't see this very frequent, that 23-weeker will really survive with the CPAP only. And do you agree that intubation, when you intubate ex-preterm, 25 and below the gray zone babies, do you agree that if you intubate, that means you need to give after intubation, if possible, surfactant, if ready on the table?
Dr. Sharma, you can ask and then I can comment if you allow me.
Yeah, I was going to say, I'm going to let you answer that first, because I'm going to be honest to say our failure rates for non-invasive CPAP, PEEP in delivery suite for babies under 24 weeks and 24 weeks is very, very high. And actually, we would like to learn from our Canadian colleagues. So I would welcome you to answer that question.
Sorry. So if you go to Canadian Neonatal Network and look at 2019 report, you will see our failure rate in different gestations. So our failure rate that in 23 weeks is 50 to 60%. So out of 10, we can we have 4 babies, 4 to 5 babies are never intubated in the first week. For 24 weeks, our failure rate is way low. So again, when you intubate a baby, that's mean, and the baby is below 27 weeks, our guidelines or surfactant, you have to give surfactant. Now, it's not about the indication to give surfactant or where to give surfactant, is the time of giving surfactant and the whole package. So you need to control the temperature, you need to control the sugar, and the baby is, if you want to give surfactant, there are 3 factors driving the surfactant in. First, the positive pressure. Second, the negative pressure. Third, the capillary diffusion or the surface diffusion, sorry. So having the caffeine hitting the baby before giving surfactant is something good, because this, if the baby was apneic and not breathing, you're losing one of the factors that driving surfactant in, because when the baby breathes by his own, he's trying or she's trying to recruit her lung. And when you're breathing in and you're sucking the surfactant by your own, you're trying to bring the surfactant to the collapsed alveoli, not when you force the surfactant by your positive pressure. So the point is not the indication of surfactant. The point is not where to give the surfactant. It depends on your setup. You can give it in the labor room, but what I meant, and maybe some people understand me wrongly, and I can tell you that I have 500 record of first hour of life by video, not only attending, but recording it. Is the whole package. Is you need to give a good delay cord clamping. You need to give a good sealed CPAP. You need to control the temperature. You need the sugar. So what we do, if we do 2 trials of peripheral IV, if we fail, we go for UVC. If we fail the peripheral IV and we cannot put the UVC for any reason, we use glucogel to prevent low sugar. We are very keen and meticulous of controlling the temperature. As keen as we are in keeping the functional residual capacity. And we are very keen to give the caffeine and the sugar within a time. So we have a timetable, and I can share it with you. A timetable on when to do things. When to do surfactant, when to do sugar, when to do caffeine, when to give antibiotics, when to do blood work, when to move the baby, how long you try, like a timetable that. And the other point that we do, and I think it's a different from Alok, and maybe he's doing it, but he did not mention, is our checklist. We have a briefing and debriefing checklist with each step we do, and we are dedicating a person to do a checklist. So again, is not where or whether to give or not, is when to give it, the surfactant. Yeah. And if you are intubated and you are below 27 weeks, you're absolutely right, you have to give surfactant. But remember the whole package, and remember that the hypothermia, so if you want to do a quality project, measure your arrival temperature, NICU arrival temperature.
Sure.
And I can tell you that it's way detrimental than surfactant given. Yeah, go ahead, sir. Sorry.
Our discussion was about that specific case with the baby 23-weeker prom and not briefing, intubated, and then you disagree with giving surfactant that time. So here I'm asking that now trying twice the IV cannula and trying the UVC, you are exposing the baby under the resuscitator to really cold weather. And I guess here the temperature with these trials and things will go down before even giving the surfactant. Before giving the surfactant. So
yeah, can I
control the temperature?
Practically, yeah, this is you are exposing the baby, because you will take his hand out and maybe the other hand to try for IV peripheral cannula. Then you will try the UVC and all this before giving the Curicef. Here you intubated the baby and you are delivering PIP through stiff lung. So my understanding from before that intubation really need urgent in my opinion, surfactant to lower the pressure in the alveoli and lessen the harm which will be caused to this lung early as possible. If you succeed in the IV cannula very quickly on half kilo baby or 400-gram baby, this is very good, but at least it will take 1 to 2 minutes. And exposing the baby that time to he's not in the plastic, the hand is not in the plastic bag. So I doubt that the temperature really maintained in this situation. So what do you think? Because we are doing this on daily basis, and I find it that it's really helpful to give the Survanta first, and then to do the other things, UVC and first shifting the baby to. We don't do it in the MDU. We do it in the in ICU.
Natasha, if you would allow me, so can I ask you a question? I'm just curious. I mean, you intubate the baby, yet you keep its temperature stable. So if I say that you take its hand out of the plastic bag and you try to cannulate it, how is that different from the intubation? They're both procedures. I think the key thing from our perspective about monitoring temperature, and I would agree that we fail. We tend to intubate most of our 23, 24 weekers. They usually get intubated and surfactant, I'd say about 80% of them, about 25 minutes. But what is really important from our perspective is it's about the mentality of it is a procedure. The question is, how can I optimize temperature despite doing it? Because you intubate despite that in delivery suite, which you're going to expose the baby's face and everything. But more importantly, one way of doing that is if you keep your temperature probes in your resuscitators under the axilla and you set servo to 37, what the resuscitator will actually do is it will keep the baby warmed on auto. And what is really interesting is we have studied hundreds of babies. I've been doing a study since 2011 on thermal care. But in 2017, we did 111 babies. And once you get that baby warm, it's like a inertia. So when you drive a car and you're driving really fast, you put the brakes on and the car takes a little bit of time to kind of come to a stop. Temperature is exactly like that. Once you start getting this baby warm under the resuscitator, actually, the risk is you can even get them hot. And the advantage of using servo control, and I'm very happy to send you a video of how we do that, but it keeps the baby warm under the resuscitator. And that's why in our setup, we've had really good thermal outcomes. I think the question is one of kind of thinking about how you do it. And I would say to you that in Cologne, they actually put umbilical lines in as part of the resuscitation. So it's not even a cannula. They put their UVC in and they give their caffeine within 60 minutes. All of that is done in a stabilization room in delivery suite. So they what
a benefit from the plastic bag if the umbilicus area is exposed, the hand is out, the face is, half of it is exposed.
So what I'd say is that things, you can still keep those babies normothermic by keeping them all parts of their body within the plastic bag, because actually your hand is slightly out. And it is about using servo measuring temperature. A good quality improvement exercise for you would be to look at your thermal care by measuring temperature from birth to arrival on the neonatal unit and seeing whether you can do it, and then seeing how you might manage to do it.
Dr. Alak, I can share with you a video of our golden hour from the birth until an ICU. We have 2 hours of record and it's live, and you can see how we I think in 2010 we have very low successful rate, and one of the important quality improvement procedures that we did is the thermal control. And actually right now sometimes we're facing hyperthermia more than hypothermia.
That's exactly
our success rate in getting peripheral IV is actually very high. We never face a hypothermia. We also, our success rate on hitting the sugar, hitting the baby in 10 minutes is actually more than 70%. And our caffeine start, we have all the data in the CNN. All there, if somebody want to read it about Manitoba. And controlling these, making it a package rather than looking at the giving surfactant as a life-saving measure is something you need. So if you want a quality improvement project, doctor, look at your thermal control and look at your NICU arrival temperature and look at when the caffeine hit the baby. And again, remember, it's a package. Intubation is a procedure. Giving surfactant is a procedure. And remember, using a CuroServe, although it looks like very nice and quick, it's very, very low volume, very high service diffusion. So I am not sure whether CuroServe is superior to Survanta or InfaServe, or I mean, the evidence is not there. But I know you give it quick, but remember, when you give it quick, you are forcing it in. And when you force it in, it will go to the open alveoli, not the closed alveoli. Now, I'm not sure, I don't have evidence. But my point is that you give it wherever you want. You give it when you're intubated, but give it in a proper time. There are things are more important than giving surfactant, which is establishing the FRC, controlling the temperature, controlling the sugar, and making sure that the baby is actually breathing. Because most of the CPAP failure, I can tell you, 50% of CPAP failure is not actually due to FRC. It's actually due to the baby is not breathing. Yep. So we have more questions, Dr. Alok, if you don't mind.
Yeah, no problem.
Yeah, I have my timetable. If you guys want it, I have a timetable of our golden hour. Somebody is asking me, and then I will share it with you, whoever wants.
Would be lovely for us as well, yeah, because we'd stand to learn a lot from it. So if you could send it to me, I'd be grateful as well.
Yeah, definitely. So the question is, let me go back to the question to you. Ahmed Dana, Dr. Ahmed Dana is asking you, what about giving non-invasive ventilation with PIP and PEEP from the beginning? Like, you're not giving a chance for the baby on PEEP.
Yeah. So you're kind of alluding to the use of BiPAP and delivery suite. I'll be really honest to say that I have, there are trials which have looked at use of NIV. At the moment, having read those papers, I can see no evidence that actually says that NIV results in better outcomes, especially under 26 weeks as compared to routine use of mask-based PEEP. Again, there is at least one study that looks at mask-based PEEP versus BiPAP, again, which showed no difference in the incidence of intubation, delivery room need for intubation, subsequent intubation, and oxygen at 36 weeks. In my practice, I think the question is, it's a lot of equipment, because you're then taking the BiPAP machine down to the delivery suite. You can use it where there's an anticipated preterm birth, but for imminent preterm birth, you know, if you're delivering about 100 to 150 preterm babies under 32 weeks, how do you ensure you're going to get a BiPAP machine? If you start thinking of using NAVA in that setup, it's very expensive. You know, to have one device, I think the practicality is about staying with what works for you in your setup, standardizing your resuscitation practice based on the resources that you have, so that you can get good at using that in order to optimize your non-invasive ventilation. And I would say that if you're using mask-based PEEP, there are colleagues of mine, Peter Reynolds, who works in Chertsey, they use high flow and they use it very, very well. And they, like Yaya, have got very good outcomes with being able to keep and use high flow, humidified high flow device for resuscitation from birth, which they've attached onto their resuscitors. So I think that's where, from our perspective, it's about learning about these practices, sharing them, and seeing whether those are practices that are applicable to your setup. But I don't know of any high quality evidence that demonstrates that either BiPAP or using bi-level CPAP is any better than using a mask-based approach or routine delivery room PEEP using a mask.
Dr. Rola is probably commenting, not asking a question. What we implement in delivery room will be reflected clearly on baby's outcome. Isn't it clear that delay in resuscitation or oxygen supply, patient will have delay in the expected pulmonary vasodilatation, and this will put baby at risk of secondary apnea sooner or later?
I think the study that's been done by Decker et al. Alludes to this, and they worry that we're in a situation where if we do not titrate the oxygen levels sufficiently enough, the hypoxemia inhibits breathing. It will cause and prevent pulmonary adaptation through pulmonary vasodilatation. The difficulty for us is we don't exactly know what level of oxygen the baby stabilizes at, and we don't know for each individual baby where that fits. So if you have a steroided boy who's 800 grams, born at 26 weeks, he might not be as good as a steroided girl with no risk factors for sepsis and intact membranes. So there is a variety of factors that individual babies have, which impairs their ability to transition. And it's, I would say, in a way, a hit and trial approach. I think what you have to do is standardize your recommendations and audit your practice. So it might mean that you practice and you start with an FiO2 of 30, but in your setup, your preterm babies, and you might have very high infection rates. And for that reason, they might need more oxygen as compared to the babies that are born in a different setup where infection rates are very low. Similarly, in my setup, we have a lot of babies who deliver electively cold sections for maternal indications, say, for example, where lungs are compromised, are better because these babies are growth retarded for PET, say, for example. So actually those babies being growth retarded, they tend to do much better in their honeymoon. So actually, from our perspective, some of these babies don't need a lot of oxygen at all. I think what you've got to do is look at the current evidence and agree a practice which is within the norms of evidence-based medicine. And I would say starting resuscitation at 30% FiO2 for babies under 35 weeks would not be an unreasonable approach at this particular point. And then titrating up or down based on your saturations using Dawson's charts.
Dr. Alok, I'm sharing with you my screen, and if you can see our timetable, gentle, golden hour and gentle care.
Are you okay if I take a screenshot?
Oh, no, I will send it to you. No
That's
problem.
great.
You can see that within 2 minutes, we do delay cord clamping. And within 2 minutes, we start CPAP. And within 10 minutes, we insert a PIV. And within 10 minutes, we start the dextrose. And within 20 minutes, the caffeine should hit the baby. And you can see the surfactant timetable is start somewhere after 30 minutes up to 2 hours. And you can see our blood work and antibiotics, we recommend anywhere between 0 and 60 minutes. Yeah. And our central line anywhere between 0 and 45 minutes or 45 minutes, somewhere like that. Mm-hmm. So these, if we don't achieve these, then you have to comment why you couldn't achieve it. And then other times for X-ray if you're not doing ultrasound. Yeah. And we don't warm the surfactant until the baby delivers. We don't warm it pre-time. So even if we want to decide to give it, it would be not less than 20 minutes because it takes 20 minutes to warm up.
Yeah, yeah.
So I'm going to send it to you, but that's just sharing it with everybody else. So more question to you, Dr. Sharma, if you allow me.
Yeah, please.
Dr. Mo Bahari is asking, recent NRP suggests delay cord clamping for 30 seconds, even if the baby is not stable, and 60 seconds if the baby is breathing. What is your practice?
So I think at the moment, our practice is delayed cord clamping. That's minimum, I would say 60 seconds. The way we do it is from birth of the baby. So once the anterior shoulder of the baby delivers, we're kind of in a situation where we start our APGAR timer. The baby will remain with intact cord. And in that phase, we always have prior agreement with the obstetricians that they are closely assessing whether the baby is breathing. They can assess cord pulsations, say, for example, by holding onto the cord. The baby goes into a sterile plastic bag or a plastic bag. And I think from our perspective, if there's no need for initiating resuscitation urgently, and a good example is if I get a 25-weeker who's completely white, who's not breathing, who say, for example, is in a situation where there is a predisposing condition, mom has placenta previa, there's ongoing bleeding, then in those situations, we would go for immediate. So the communication around the circumstances after the baby is born in making the assessment of physiological stability of the baby and to see that it's adapting. Some, a proportion of babies, even at that gestation, will come out breathing, some will cry. And those are babies who lend me reassurance that actually it's safe to carry out DCC. On the other hand, if I get a baby where the mother's bleeding and it looks pale, and say, for example, the obstetricians feel that the heart rate's extremely low or not difficult to feel, we would stop, clamp the cord in the baby. So it's individualized and it's based on the baby. I think a blanket approach of saying that I'm going to do 30 seconds in all babies. Well, if you have a baby with fetal bradycardia, who's not got a heart rate, who's just lost its heart rate 10 minutes back on CTG at 25 weeks, and they come out not breathing and white, I think, delaying resuscitation in that situation would not be my practice.
Okay, so the question is from Dr. Muhammad is, can X-ray alone be an indication for surfactant?
Never. Okay, so I've just contradicted a statement of my own. Never say never in medicine, but my experience would be that actually what is really important is looking at your baby clinically and holistically. I think the key things from our perspective are determining and trying to elucidate whether this baby has got respiratory distress syndrome. So if you take a 32-weeker, for example, steroided girl, now she may have work of breathing, but she might have fluid, not surfactant deficiency. That's the problem. But will an X-ray really differentiate TTN from RDS early on? It might not. You might have an appearance that is consistent with either. Or say, for example, if that baby's got infection, group B streptococcus, the X-ray appearances are not pathognomonic. So the risk in that situation is if I just trust the X-ray and I end up intubating and ventilating that baby and it's actually got infection or transient tachypnea, I might not be doing that baby any favors. I think what you have to do is you have to look at the baby clinically. You have to look at the baby from the perspective of and when you do this, you can use lung ultrasound. So Dr. Yaya is teaching us lung ultrasound these days, and there's a very good sensitivity of being able to diagnose RDS and differentiate it from TTN, even in preterm babies using lung ultrasound. So I think it's looking at the baby as a whole, making a diagnosis, and then the question you're asking yourself is, what am I treating? Because if the baby has just work of breathing but is in air, the baby may not need surfactant. It might not have RDS, and just putting the PEEP up because there's fluid, recruiting that baby through providing appropriate non-invasive ventilation is the way forwards. So I would be reluctant to say that one investigation like an X-ray would help differentiate and determine whether the baby needs treatment with surfactant.
Even ultrasound. So imaging alone is not an indication. It should be like a package. I do have something called surfactant tool. If you guys want me to share it with you, I'm happy to do so. It's the tool that we use for the time and the indication of when and how to give surfactant. So if somebody wants it, I'm happy to share it, but doesn't mean you have to follow it. It's just the way we do things. So a question, Dr. Sharma, is from Dr. Jafari is, do you get EBM in the labor room or donor? He's asking whether you're giving EBM or DBM in the labor room.
So what I'd say is that from our perspective, where possible, EBM, and we encourage what is called EBM harvesting. So when the mother comes in, even if the baby is extremely preterm, we ask her to harvest her breast milk before the baby is delivered, so that we will have EBM available to start mouth care pretty much within the first few hours of birth if the baby is physiologically stable. And I would say the majority of babies would be physiologically stable for you to start mouth care. I think the key thing from our perspective is donor does need consenting for the parents. And it's not something that we would routinely use for gut priming, because we often are able to get the parents, the mother, to be able to express. And we start very small amounts, of milk for mouth care. So not a large amount is needed.
So I'm going to share a little bit of screen. So this is my surfactant tool that we use, depending on the gestation. That's how we use it. And I have it as also on as a flow chart. So if somebody interested that I can share it with. is, and you can see the first line is written in our line is surfactant is not an emergency medication. So more question, Dr. Alok, is what is the target body temperature after resuscitation in delivery room?
Okay, so that's a fantastic question. So if you look at the literature, and again, this is all work that's done by the Canadian Neonatal Network, there is an inverse relationship between admission temperature and outcomes when the temperature is below 36.5 and above 37.2. So outcomes, and what I would say is that for hypothermia, there's a good link between a baby arriving hypothermic, higher incidence, higher mortality, higher incidence of NEC, higher incidence of late onset sepsis, surfactant inactivation. So if your temperature on arrival in the neonatal unit is less than 36.5, theoretically, that's a quality indicator for us. So that gets reported to our national neonatal database, and we get compared to other units on our levels of hypothermia. But as of last year, hypothermia is also now a quality indicator, and a temperature above 37.5, from our perspective, is considered to be a poor thermal outcome. So it's really normothermia that we want to achieve. So keeping a temperature between 36.5 and 37.5 is the norm. And in our setup, we use servo on the resuscitator. And what we've been able to do is eradicate hypothermia completely. We have problems with hypothermia. And I think the question from our perspective is, again, some of that might focus around getting babies warm, but some babies, obviously babies want a chorioamnionitis, mothers who have it, chorioamnionitis might actually be hot from birth. And we've, the question then is, those are babies who actually, you need to be careful about warming too much. But yeah, you're aiming for a temperature between 36.5 and 37.5 on admission to the neonatal unit. We're currently doing a study to actually compare the thermal outcomes of babies who are hypothermic and hypothermic in the first 12 to 24 hours after our golden hour management. So we're looking at our practice over the last, since 2017 to 2020, to look at babies who come in hot and cold and see whether and how their natural history of temperature is within the first 24 hours. And we're correlating that with our clinical outcomes locally.
Okay, the rest is just complementing to your work, Dr. Sharma, and thank you for all the knowledge and all the wisdom. And I would also thank you for doing this. It was a great pleasure. And again, when I said I strongly discourage, it does not mean that I am preventing, but that's my view or my way of doing things. You have all the right to do the ways you think you're okay. But usually I try to go by evidence-based medicine. And if somebody was offended by the word I strongly discourage, then please accept my apology. Thank you very much, Dr. Alok, for all this, and I wish I see you in other webinars.
I'm grateful. Thank you so much. And thank you for inviting me to speak. And I'm grateful to all the participants for their time. Thank you for all those questions. You've helped me learn. Thank you so much.
Thank you very much. And I will share these two documents on YouTube. If you go on the video that of Dr. Sharma presentation, you will see in the comment that I will upload the documents, and you can personally contact me. If you cannot get it, I will send it to you. I will share it with everybody. But these, remember, some of them are not evidence-based, they are just an observational, or sometimes they are physiological-based medicine, not evidence. So not all what we do is about basement. So if you want it, it's all yours, but you practice it based on your decision and your own, this is things that you have to decide, not me.
Thank you.
Thank you very much. Thank you, everybody. Enjoy the rest of your day. Assalamu alaikum.
Assalamu alaikum.